Hello students, hello, welcome to the session from where we are streaming. There is some lag. Am I visible to all? Am I audible to all? Yes, excellent. All clear. Thank you very much. Thank you. Yes, superb. So just a second. We are just on the... Yes, so from where we are streaming, there might be a slight lag, and all of you, I think I'm visible to all, audible to all. Yes, okay. Thank you very much. All of you, good afternoon. Thank you. OG in the chat box. Welcome, all of you, my dear students. Welcome to this very important session. Just exactly, we are starting now. Yes, excellent. And I can see all of you. Super. Welcome all of you. It's going to be a very fabulous session. All of you are going to enjoy it. And last time when हमने जब किया था majority questions, yeah, yes, bacha, very good. Okay. Yes, many questions had come in, and this is our rapid revision course. This is our rapid revision for the upcoming FMGE examination. Okay, and before we proceed further, I request all of you, you can get in touch with me on phone and WhatsApp on this number. And if you have any difficulties regarding your preparation, this specific session is for the Jan FMGE student, the rapid revision course. Yes, and very quickly, 10 seconds, clap if you feel happy. Quickly start following me on Instagram. Very important reels we are following, putting it every day, and PYQ questions we are doing. So please take, how many? Yes, better we'll see. And please subscribe to my YouTube channel. Also very important, we are putting the PYQs and regular revision. All that is coming on my YouTube channel also. And the PDF material will also be available on Telegram. So quickly, just take 10 seconds, all of you. Yeah, OG in the chat box. Thank you very much. And thank you, dear students, for coming in such big numbers. Please follow on Insta. Exactly 10 seconds lagega. Please follow on Insta and please subscribe to the YouTube channel also. And very happy to announce, many of the students were asking me, sir, aapka live batch is starting when? So more about this later on. Quickly download the OGGuru app and use the coupon launch30 just in 849 rupees. 9 days starting from 8th of December. 8th December to 16th December, 17th December, way 1 month before your FMG exam. I'll be preparing you, and we are going to take 9 sessions live, 90 minutes, 9 sessions only at 849 rupees. Entire OBGY will be covered. My dear students, the single most important subject, 30 to 35 MCQs are going to come in OBGY in the FMG examination, and everything will be from my app and my lectures, my guarantee. We're going to discuss all the MCQs, PYQs, IBQs, live doubt solving, and then you can see the lectures afterwards also along with this. Okay. And the lectures recording will be available till 20th of January. Okay, so just at 849 rupees, quickly download the OGGuru app and join me, and I'll see you live at 8th December in the app. Live lectures will happen for 90 minutes. Okay, now let it be like an interactive session. I want all of you to answer and participate. Right, wrong does not matter. Wrong ho gaya chalega. It is okay to be wrong over than to be wrong in the examination. Okay, so first question, chalo, tell me first the diagnosis approach, clinical case. Directly we are starting with a clinical case only. Longest question. Okay, right, wrong does not matter. Okay, very good. A Krishnakant. Okay, yes. Yes, thank you. Yes, thank you for, yes. Yes. So now please pay attention. Now I will just slightly first, this answer I'm giving you. Okay. This answer I'm giving you. Wait, just very similar. Next question. Now what is the difference? Okay. Again, 24-year-old married lady, married for 3 years. She is obese, facial hair, hirsutism, also irregular periods, LH levels given to you, FSH levels given to you. What is the most appropriate treatment for her condition? Arey sir, you are given the same question. Nahi, there is a difference. Dono question mein there is the difference. What is the difference? Yes, very good, Tanya, Firdaus, all of you. Yes. So now I'll tell you how the question is differing and what it is. Okay. So please pay attention, all of you. Please pay attention, all of you. Okay, yes, sir. All these. Now, which criteria? No, age name. Which criteria we use? So this is your diagnosis based on clinical scenario is PCOS. Short topic. Okay, मैंने most important selected topics have selected for all of you. So all these are hot topics which you have to know. Okay, so we have got obesity, irregular periods, acne, hirsutism, infertility. So clinical basis पे the diagnosis is PCOS. Very good. Rotterdam criteria are used. Any 2 out of 3 is okay. Rotterdam criteria says, what is it in the Rotterdam criteria? Sir, an ovulation. That is like an ovulation is because of is leading to the is the main problem, and an ovulation is going to give you irregular periods, okay, as well as infertility. Second, so an ovulation के वजह से होता है mainly infertility. Second is your clinical or biochemical hyperandrogenism. I'm writing hyperandrogenism. Clinically means what? I can see, sir, acne, hirsutism. Okay. And third is the or clinical or biochemical means elevated testosterone levels. And third is the sonography criteria. Third is the sonography criteria, which is that famous necklace of, yes, acne, hirsutism on the face. Very good. And third is the ultrasonography criteria. 12 or more than 12 follicles. Okay, 12 or more than 12 follicles. And what is the size of the follicles? Anybody in PCOS? Sir, PCOS में होता है छोटा छोटा small follicles. Okay, all follicles are छोटा famous necklace of pearl pattern. Yes, 12 or more than 12 follicles. The follicle size is 2 to 9 millimeter in size. So all these are immature small follicles. Okay, so actually yes, and the famous necklace of pearl pattern. Okay, in fact bacha log, in fact it is PCOS is a misnomer. There is no cyst in the ovary. It is polyfollicular. So there are multiple small follicles. Any 2 out of 3 have to be present. Now the most important point which all of you need to keep in mind is okay, for this PCOS always the treatment will depend on what the patient wants. Is it always clear? There's no one drug of choice. The treatment will depend on what the patient wants. So if the patient says, doctor, I am having infertility or I am planning pregnancy, can you tell me one word answer? Why is there infertility? Yes, we are coming to that. Diet, yes, very good. Why is there infertility? One word answer. One word answer. PCOS में infertility क्यों होता है? Yes, sir. The infertility is because of an ovulation, and therefore for the treatment I have to go for ovulation induction. And remember, my dear student, letrozole, clomiphene was the answer. Now wrong. Okay, so here, sir, coming to our first MCQ, married for 4 years and complains of infertility. Infertile patients में you can't give ossipils. Okay, और patient बोलेगा डॉक्टर पागल है, डॉक्टर पागल है. भाई डॉक्टर पागल है because sir I have come to you for planning pregnancy, you are giving me birth control pills, so that will not work. And clomiphene citrate, many students feel, but it is wrong. Clomiphene citrate, write down, was the drug of choice. Now it has found out, very good FMGE and Modi Manav, letrozole is now, write down, the first drug of choice. Clap if you have learned something new. So the answer is, okay, sir, the patient who is infertile will require ovulation. Yes, I need you. If you need to get pregnant, you need to give her letrozole. It's the first drug of choice for ovulation induction. What more you will give? Also, I will tell you in some time. Okay, don't worry about it. But now over here, yes. So coming to it, letrozole is preferred, and if she does not respond to this, then it is we'll give other medicines. Now, second set of patients is, doctor, I am not married, or even if I am married, right now I don't want pregnancy. So right now please give me treatment for irregular periods. I want treatment for irregular periods. I want treatment for acne, and I want treatment for hirsutism. So एक ही गोली made for each. How will you remember this, my dear student? They are made for each other. Clap if you feel happy. PCO, invert, flip, ulta kar do, OCP, Thokotali. Clap if you have learned something new. PCO, OCP. That's the way to remember. All the problem. Nobody will teach you like this. OG in the chat box. PCO, OCP का मतलब ये है कि सर all the problems of PCOS, whether it is irregular periods, acne, hirsutism, even future risk of endometrial cancer, is beautifully controlled by taking OC pills and symptomatic management. Is this understood to all of you? Clap. OG in the chat box. Yes, thank you. So here, my dear student, she is married for 3 years. See, starting part of the question, they are diverting your mind. Okay, sir, she is married for 3 years. So could it be infertility? Starting mein aapko, they are confusing you on purpose. Okay, but clearly remember, she has come for treatment of hirsutism. That is the clincher. Okay, sir, since she has come for treatment of hirsutism, I will not give her clomiphene letrozole. And ovarian drilling to is almost like outdated kachra dustbin. Outdated kachra dustbin, it's almost never done. Okay, and here again, so she has got acne, hirsutism, and this LH to FSH ratio also. Okay, see the FSH to LH ratio in this MCQ. In this MCQ, 9:36. So that is 1:4. That is because LH is on the high side, and therefore the answer over here is OC pills. Is this understood to all of you? I repeat, the first question is PCOS with infertility. So we will give letrozole. The second MCQ is again PCOS, but she is planning treatment for acne, hirsutism. She wants treatment for acne, hirsutism, irregular periods. I gave her OC pills because OC pills will decrease they have got anti-androgen. And specifically, can you tell me which OC pills? Which OC pills? Can you tell me which OC pills are better? Sir, the OC pills which contains what? Sir, the OC pills, higher information, PG level. The OC pills which contains cyproterone containing OC pills. Okay. Cyproterone acetate. Cyproterone is what? So cyproterone is a progesterone. It's a progesterone with a anti-androgenic property. Okay, so that is better, cyproterone or drospirenone. And don't forget, my dear student, this was asked last year, okay, all patients of PCOS, the management, because we know there is insulin resistance, and therefore yes, diet, exercise, weight loss is very, very important. Is this understood to all of you? Diet, exercise, weight loss, and that is called as lifestyle modification. Very important MCQ. Lifestyle changes, lifestyle modification, and therefore very good to both. We can add metformin. Metformin is a insulin sensitizer. It can be added to both. Matlab you can give it with letrozole also or with OC pills. Metformin will tackle the problem of insulin resistance. Yes, initially, always the initial management is this: diet, exercise, lifestyle management. You have to give it. Is it clear? Yes. Myo-inositol is also very good. Allah the Greater. Yes. Myo-inositol is also available. Myo-inositol is a newer insulin sensitizer. Okay. Metformin can be used. But this initially yes, so depending on what the patient wants, because directly with diet, exercise, weight loss will take a lot of time. So side by side you start giving her letrozole also or ocipils also, side by side, everything happens together. Okay, everything happens together. Okay, is this understood? Now a word image based MCQ, directly image. One more very difficult. Okay, lots of images I'm going to show you. Majority are MVP. What is MVP MCQ? Most important, virgin and PYQs. Okay, so this is okay, and definitely download the OGGuru app and get in touch with me on phone and WhatsApp. I'm personally guiding the students how to study, how to prepare. Yes, now what is the picture showing you? What is the picture showing you? And this procedure is performed at what weeks of gestation for antenatal detection of trisomy 21? So if you see the liker, this is the under sonography guidance, this is the baby, and our needle, the needle is in the liker pocket. We are sucking out the amniotic fluid. So what is the procedure? No, what is this? This, my dear student, is amniocentesis. Yes, this is amniocentesis. If you zoom and see, the needle is in the liker pocket. Okay, so if this is the baby, this is the baby, you will enter. Okay, you have to be away from the placenta, is over here. You will enter the liker pocket. Don't touch the baby. Needle should not touch the baby. And you will be, fluid is black. Fluid is black on USG. So in the liker pocket, we will suck out and we will do karyotyping. And can you tell me, karyotyping is what kind of a test? No, FMG, it's not for congenital anomaly. Congenital anomaly is ultrasonography. This is karyotyping chromosomal. It's a confirmatory test. It's a confirmatory test for any trisomy or trisomy 21 or any genetic problem. Yes, genetic and chromosomal. Okay. No, watching this only is not enough, because this is going to be our session. And but I'll tell you this, you can get in touch with me, this one. Yes, Kadri, okay. You can enroll in the live session starting from, yes, that will be more than enough, because 9 sessions are there, 90 minutes each. So 15 hours we are going to do. Yes, very good. So this is amniocentesis. We don't do at 8 to 13 weeks and 10 to 13 weeks. No, amniocentesis is always in the second trimester, T2. T2, and very good. Therefore, the answer is either basically anytime after 14 weeks. Okay, after 14 weeks. Shri, sir, I will be putting it on my Telegram channel. Okay, beta, PDF, you will get it. The annotated PDF, I'll put it on my Telegram. You can follow from there. Okay, so after 14 weeks is the answer. So 15 to 18 weeks is the answer. Now, 36 weeks is too late, isn't it? Because for detection of trisomy 21, it's a chromosomal problem. We want to detect it before 20 weeks, so that we can do MTP and all that. Okay, is it clear to all of you? So 8 to 10 weeks nahi hai, 15 to 18 weeks is the answer. Okay, so is it clear? So this is amniocentesis, which is done in the second. Can anybody tell me which is the confirmatory test? So one confirmatory test is your karyotyping is the only confirmatory test. You can either do it by amniocentesis, which is another test, which is done in the first trimester. No, triple marker test, but it's a screening. All that we are going to discuss that. Triple marker, quadruple marker or screening. Another confirmatory test is chorionic villus sampling, which is done in the first trimester. Okay, amniocentesis is done in the second trimester, T2. Yeah, NT is again all. Okay, all that we are going to discuss. Sab aane wala hai. Remember that, my dear student. Okay, so chorionic villus sampling, not the triple marker, double marker. Why? We are going to discuss that in some time. Stay right till the very end. Okay, yes. Now, chalo, tell me. Again, a very important PYQ. 22 weeks pregnant lady with occipil failure requesting for MTP. As per the latest MTP Act, what is the answer? Yes. A. How many for A? Can be done with this. No, wrong. Why? Because all clean bold. Clap if you will learn something new. Okay, so please pay attention, my dear student. Okay, as per the new MTP Act or the latest MTP Act, MTP was allowed till 20 weeks of gestation. Now we have increased it to 24 weeks. But this 20 to 24 weeks is for what? Which indications? No, it is not telling you, okay? For which indication is this 20 to 24 weeks allowed? Okay, so see, overall MTP can be done for 4 reasons. If it's a rape, sexual assault, chromosomal, genetic, mother's health, baby's health, all this. Yes, yeah, only for some. So sir, this 20 to 24 is if there is some genetic problem in the baby, chromosomal genetic or structural anomaly in the baby, because sir, sometimes the anomaly is detected at 22 weeks, 23 weeks. So because certain anomalies, so any chromosomal or anomaly in the fetus, yes. And second, yes, if for rape and sexual assault victim, they would be coming late sometimes. And they say there are some special circumstances. Of course, to save the life of the mother is there only. Mother ko life, to save the life of the mother is any time. And there are certain special circumstances like divorce during pregnancy, or couple undergoes divorce while she is pregnant, all that stuff. Okay, so mainly remember, okay, sir, for sexual assault victim and genetic chromosomal, this elevation is allowed. Yes, change in marital status, very good. But all of you remember this. Okay, sir, for failure of contraception, it is still only till 20 weeks. I'm so happy I teach this every year. And this question came last year. Yes, failure of contraception is still only till 20 weeks only. If your condom has stone, अगर कॉन्डम फट गया है, you can't be sitting at home till 24. You need to come early. Come at 6, 8, 10 weeks, latest 20. Okay, so therefore here clearly, my dear student, patient has come with OC pill failure. This is a contraception failure, and therefore I cannot do it. You don't need permission of hospital superintendent and not medical board. Medical board is for anomalies after 24 weeks. Okay, after 24 weeks, if there are some anomaly in the baby, then the medical board everybody sits, the radiologist, gynecologist, pediatrician, and then they give permission, special case may. So anomaly beyond 24 weeks, you need medical board. This is actually MTP is not allowed, but yes, can be done if we detect a anomaly in the fetus. Is this clear? Okay, sir, by yes, double indication ho sakta hai. Okay, so for failure of contraception is still only till 20 weeks. But by chance, if I do a scan, and scan may I find out there is anomaly in the baby, then yes, हाँ लिखा हुआ है ना, yes, so correct है, so correct, that's the answer, yes, that is it. Is it clear? Okay, if can be done, yes. So by chance, if at 22 weeks for failure of contraception you cannot do, but if it is anomalous fetus, then I can do it. That's the answer, can be done only if. That is the question. Yes, क्या doubt है बेटा? नीरज सिंह, yes, clear, क्या doubt है आपको बेटा? What is the confusion? Yes, so upper limit is 20. Is this clear to all of you? The very important MCQ. Okay, so 20 is for failure of contraception, still only up to 20 weeks MTP is allowed. Okay, is it clear all of you? Yes, my dream correct. Neeraj Singh, please tell me yes or no if it's clear or not, and tell me if your doubt is clear. Okay, sir, if the question was, yes, very good. Okay, if the question is up to 20 weeks hai, then yes, failure of contraception is allowed. This 20 to 24 is for genetic problem in the baby, structural anomaly, rape, sexual assault, all that. Failure of contraception is only till 20 weeks. This is a 5-star which you remember. So Change of marital status is, beta Helen, that one husband dies, or husband undergo divorce. They undergo divorce, so she does not want a baby. Then you can undergo MTP. That's how special says. Okay, so I can only do it, yes, if congenital anomaly is present in the fetus. Then because we are 20 to read the first word. First word you need to read. Is this understood to all of you? Yes. Moving on to the very important, what is this glucose challenge test or the glucose tolerance? And for diabetes in pregnancy, that means gestational diabetes, GDM. Now can you tell me first of all, what is the ideal time to do the test? What is the ideal time to do the test? Okay, the test is recommended when? How many? If I tell you 10 weeks, 20, 26 to 28, 32, 16, 18, 20, क्या होगा? Okay, when to do the screening? Suppose I give you mother life danger, you can, yes. When to do the test? Suppose question होता है 14, one more MCQ bonus, 14 to 18, 20 to 24, 24 to 28, 32 to 36. चलो, tell me the answer. A, B, C, D. Yeah, but ideal time. Okay, so the ideal time to do the test is 24 to 28 weeks of gestation, because that is the time when the insulin resistance is maximum in pregnancy. Very important. Clap, clap, clap. Thoko tali. Okay, so 24 to 28 weeks is the time when there is a maximum insulin resistance, and therefore we will be able to pick up maximum number of cases. Is this understood? And in India, what test? Yes, because okay, we are using the DIPSI test. Clap if you have learned something new, something very new information. What is this DIPSI test? DIPSI का full form क्या है? Okay, so DIPSI is diabetes in pregnancy, diabetes in pregnancy study group of India. Okay, so Indian guideline study group India, and here we recommend 75 gram glucose. Very good, 75 gram glucose. And after how many hours do we check the sample? After how many hours do we check the blood sugar level? So 75 gram patient will open up the packet, half a glass of water, drink it. Okay. Fasting, okay, but fasting not required. Can be done any time of the day. Preferably fasting, but fasting nahi hai to bhi chalega. 75 gram glucose. Very good. We have to just remember one value. Okay, sir, this 75 gram glucose is given, and after 2 hours, we will check the plasma glucose. And what is the cutoff? Anybody with a cutoff? It should always be less than 140. Less than 140 is considered normal. Yes, less than 140 is considered normal. If it is more than 140 milligrams, then the patient is considered as a case of GDM. So please by heart all this number. And 75. Please understand this, the ACOG is recommending, and ACOG ka 100 gram hai. That is not what is followed in India. Okay. The GTT which ACOG is fasting 1 hour, 2 hours, 3 hours, all that. Okay, so more than 140 is a case of gestational diabetes. Is this understood to all of you? Single step test, which is very important, ideally done between 24 to 28 weeks, because it is the insulin maximum. Moving on. Next, again, very important topic. Chalo, so all most important MCQs I have selected for all of you, my dear student. Now, this is a patient. Nulli gravida is very, very important word. Nulli gravida means she does not have any babies and she wants babies in the future. She wants baby or pregnancy. Third degree prolapse. What is the treatment of choice? Anybody? How many for hysterectomy? How many want to do hysterectomy? You have to go to jail. Okay, why jail? Because sir, if in a 24-year-old nulliparous patient mein, if you do hysterectomy, you have to go to jail. Jail matlab it's a crime. Okay, clap. Tocotali, smiley emoji. Okay, to jail. Okay, similarly, Leafold's operation is only for, we are closing. Leafold's mein we close the vagina. Vagina ko band kar dete hain. No entry. Vaginal sex is not possible after Leafold's. So it is only for postmenopausal patients. When specifically, we'll discuss that when the family is complete sada, when she is not fit for surgery. Okay, when the patient is not fit for surgery. Okay, and can anybody tell me why will I not do Fothergill surgery? Why Fothergill should not be done? Why Fothergill should not be done? Yes, sir. In Fothergill surgery, yes, because in Fothergill surgery, what is the main step? Anybody? Sir, in Fothergill surgery, remember, we are doing cervical amputation. Okay, cervical amputation is done, so that can lead to stenosis, infertility, and what complication? Anybody? Yes, cervical amputation hoga, so either the cervix becomes too tight and there could be cervical stenosis, infertility, and also cervical incompetence. Cervical incompetence, where she will end up with abortion specifically in the second trimester. Already we're going to discuss, उसके ऊपर भी question है. So cervical incompetence होगा. So Fothergill should always be avoided and we should not be doing it, or we should avoid it, because she is a nulliparous. And my dear student, the way to remember this is, all of you, 2010 Akshay Kumar movie Singh is King. Yes or no? अक्षय कुमार, कटरीना कैफ, डोंट, नाइस मूवी, बट अभी मत देखना, एग्जाम के बाद देखना. ओके, सिंग इज किंग. Yes or no? Sing is King movie had come and all of you will remember. Yes sir, Sing is King also. Sing is King also, but Sling is King. So Sing is King और उससे अपने को मिलता है Sling is King. Okay, and therefore Sling is King. Sling is King matlab Sling is the best, and it is done through the abdominal route. So we call it as abdominal sling surgery is the best when the patient is a young patient, nulliparous patient. So Fothergill beta is almost never done. Tick tube city. Fothergill is almost never done nowadays. Okay, Fothergill नहीं करते हैं. Avoid. Almost never done. Okay. Yes, Shirodkar sling, Purandara sling, also sling. And another name is, anybody? Another name is also called as cervicopexy. So sling surgery का दूसरा नाम है cervicopexy. If that is in the option, mark that as the answer. Okay, cervicopexy is another name for sling surgery. ठीक है, clap if you have learned something new on a Saturday afternoon. Sing is king, exam के दिन पे याद रखना है. Sing is king and sling is king. Sling is king मतलब sling is the best. Okay, and abdominal sling surgery, because here sir, she is a young patient, young, nulliparous, wanting pregnancy in the future. Okay, clap if you have learned something new. Thoko tali. Yes. Now, new style question. Now see, when this question came, student panic. These are all the new style. On my YouTube channel, there is a video. New style FMGE MCQs. Please go and see that video on my YouTube channel. Okay. Now see this. What is this? इसको कैसे करना है? So, consider the statement. Student क्या करते हैं? Directly when they read this, they start marking this as the answer. 1, 2, 3, 4. No, that is not this. Okay. Cystocele rectus beta separate. That is we have to do cyscolporaphy. Okay. What is there in cystocele rectus beta? That is a prolapse. That's a cystocele rectus bladder prolapse, vagina prolapse. It's a vaginal prolapse. Bladder comes down, rectum comes down. Okay. That is given as to cystocele rectocele. It's a vaginal prolapse. You need to do colporaphy. Okay. Tick tube city. Yes. Now to go and see the prolapse lectures in detail if you have doubt. Okay. Yes. Now can you tell me, so the question over here, these are your option starts from here. Which of the following statement given above is correct? They are talking about uterine leiomyoma matlab fibroid. Regarding fibroids. Okay, regarding fibroids. Is this understood to all of you? Yes. So prevalence is highest between 35 to 45. Yes, definitely. Always remember fibroid starts in 30, 35, goes on till 40, 45. More common in nulliparous lady. Yes. Our great जो grandparents थे उनको 5, 6, 7 children थे. So they were hardly having any prolapse. Now all of you please pay attention. What is it? Modern era. Modern era. Patient says, doctor, I don't want a baby. Okay, or late marriage, delayed marriage, no marriage, or no babies. और क्या बोलते हैं वो लोग? Childless by choice. चाइल्डलेस बाय चॉइस का मतलब है कि डॉक्टर दिस लाइफ इज फॉर मी एंड माय हस्बैंड टू एंजॉय. जिंदगी ना मिलेगी दोबारा, बच्चे देखेंगे अगले जन्म में. सो वी डोंट वांट बेबीज. दे आल्सो कॉल्ड डिंक कपल. डिंक नाम सुना है? डिंक, डबल इनकम, नो किड्स. डबल इनकम, हस्बैंड वाइफ बोथ आर अर्निंग, मजा मस्ती, वर्ल्ड टू टाइम पास. डॉक्टर एक कुत्ता पाल लेंगे, विल अडॉप्ट अ डॉग, बट वी डोंट वांट अ बेबी. ओके. So therefore, it is more common in nulliparous patients also, yes. And whenever I give GnRH analogs, the fibroids will shrink but reversible, and all fibroids do not require treatment. Very good, very good. Is your all four are correct. And therefore 1, 2, 3, 4, sir, all four statements are correct. Is it clear? Yes, बुढ़ापे में बातें याद आएगा. That's okay. Yes. So basically ding couple मतलब husband corporate job, CEO one company, wife corporate job, CEO another company, work, मजा मस्ती, world through time pass. And doctor will adopt a dog because having a baby is a big responsibility, you know. बच्चे को जन्म दे दो, school admission, college admission, NEET, PG, FMGE, headache. We don't want that. Okay, is it clear? So जो all those who are nulliparous or who don't have babies, more chance of having fibroids. Okay, so remember this, all four are correct. Not only this, all four, 1, 2, 3, 4, all. And all fibroids don't require treatment. Suppose you just have a symptomatic chotu fibroid, don't do anything. Yes. Now again, a new recent advances. Patient is brought to the OPD by her mother. Which of the following, and not yet attended periods, menarche, which of the following is considered as primary amenorrhea? Yes. So now please understand this, my dear student. Primary amenorrhea definition has changed. Yes, very good. Please understand this. The old criteria was what? 14 years or 16 years. Yes, sir. There is no periods. Periods have not yet come. So no menses, but when? Okay, if I see a girl in the OPD and there is no breast development, axillary pubic hair, there is no secondary sexual characters, I'm writing SSC. Okay, no SSC matlab is my full form for short form for secondary sexual characters. So the secondary sexual characters are absent, then even at the age of 14 I can label it. But if secondary sexual characters are present, that means the breast development is there, very good, axillary pubic hair is there, very good. So you will wait, and then by 16 we label it. But this is old. The new criteria make it one year lesser. This 14 has now become 13 years and this 16 has now become 15 years. Is this understood to all of you? With secondary sexual absent and present. Clap if you have learned something new on a Saturday afternoon. So now 14-year-old no menses but with breast development. So here we can wait. We will wait because breast development has started. Similarly, 13-year-old no menses with breast development. Here also we can wait. Why? Because it can start. And yes, 13-year-old, no menses, without breast development. This is the answer. Clap. Is it clear? 14-year-old, no menses, without breast. This is the old criteria. Old. So very good. In A and B both we can wait because breast development has started. So I will wait. I can wait till 15 years. Okay, we can wait till 15 years in this. So remember the new latest advances. C is the answer. Yes or no? Clap. The commonest cause. Anjali Gupta PDF will be on my Telegram channel. I'm giving you the link in some time. Download, join the Telegram channel. PDF will be uploaded by today evening, tomorrow morning. This entire PDF will be coming in. Okay. The commonest cause for primary amenorrhea is, yes, no, the commonest cause for primary amenorrhea, my dear student, is Turner syndrome, 45XO, and Turner syndrome is also called as ovarian dysgenesis. Ovarian dysgenesis. Okay. Or Turner syndrome is the most common cause of primary amenorrhea. ये जो number 2 है, Mullerian agenesis, we'll discuss that also in detail in some time. RMKH syndrome. RMKH syndrome is the second most common cause for primary amenorrhea. Yes, no problem. You can just join the RR course. Just we'll discuss that. Just come 9 entire day study everything. पूरा दिन आप study other subjects, study patho micropharma. In the night, just come 90 minutes every day for the live sessions, and you will do so much well in OBGY is my guarantee. And androgen insensitivity is the third most common cause. Is this understood to all of you? It's the third most common cause. So remember all the three. First most common cause, Turner syndrome. Androgen insensitivity, third most, and RMKH hormone is second most common cause. Another name, testicular feminization syndrome. Yes. Okay. Is it clear to all of you? Now, very important. Again, short, long clinical case. Tell me the answer. 100% नीरज, कुछ हेल्प नहीं होगा, बहुत हेल्प होगा, जबरदस्त हेल्प होगा, वो आपको रियलाइज होगा. यू विल रियलाइज व्हाट यू हैव बीन मिसिंग टिल नाउ. जस्ट 90 minutes come every day in the night from 8 December onwards. Okay, yes. Now please understand this. Primary amenorrhea, the clue or the trick is absent uterus. So all of you, look my dear student, whenever in the whole of OBGY, if you get a combination, of primary amenorrhea but along with it absent uterus, only two options are possible. What are this, anybody? What are the two options which are possible? The only two options possible are, sir, either it is RMKH or androgen insensitivity. Can you tell me why not? No, but inside the app. Neeraj, I'll tell you. Neeraj, at the starting of the stream, I've told you. I'll again tell you in some time. Just hold on. Inside the app. Okay? Picture abhi baki, just wait. Okay? Can you tell me what happens to the uterus in Turner syndrome? Turner syndrome में क्या होगा? Turner syndrome, why is it not over here? So when you have this combination, remember only two options, only two possibilities are there. Okay, Turner syndrome, my dear student, in Turner syndrome, the uterus is present. But, so there is streak ovaries. Yes, ovaries are replaced by fibrous bands, and therefore estrogen is not there. And uterus requires estrogen for its growth. And therefore in Turner syndrome uterus is present but uterus is chintu. कैसे बोलते हैं हम? Chintu uterus, ये hypoplastic uterus. So uterus is present but the uterus is hypoplastic or underdeveloped, but uterus is present. So remember my dear student, Turner's syndrome, Turner's, write down, is not absent uterus. Is this understood to all of you? Turner syndrome is not absent uterus. In Turner syndrome, the uterus is present, but it is chintu. It is chotu. Chintu uterus. And therefore, you have only these two things. Breast is not a difference. Breast is well developed in both the conditions. The difference is, yes, look at the hair, sir, the axillary in females. Axillary and pubic hair are androgen dependent, and therefore in my column number 1, axillary and pubic hair is present. In column number 2, axillary and pubic hair is absent. So that is the clue. That is the clue that axillary pubic hair is absent. And also they have got undescended testes, which is the lump. Okay, they will have undescended testes, which is the lump in the inguinal area. So now if you see primary amenorrhea, breast well developed, and absence of axillary and pubic hair, what is our diagnosis? Answer A. All those who said answer A, clap for Tocolytic. Okay, so in RMKH, axillary pubic hair will be present. And what can you tell me, what is the lump in the inguinal area? Anybody? Lump is felt in the inguinal area. What is it? Lump, yes, this is that undescended testes. Undescended testes is that lump in the, is it clear? That is that. Okay, so whenever, now variation, all of you tell me, chalo ek variation. Suppose if I tell starting ka same MCQ, and if I write ye lump, all of you remember this lump is felt if I remove it. Okay, and now if I say breast is well developed and presence of axillary and pubic. Chalo, tell me, ek pe ek MCQ free. Now what is the answer? Now what will be the answer? Clap, 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 thoko tali, superb, my dear student. If axillary pubic is present, then the answer becomes RMKH. RMKH, ovaries are the gonads and well developed axillary and pubic hair. Is this clear to all of you? So see how in the exam, ek word, one word change, and so I'll make it to the original question. This lump is the undescended this. Okay, so androgen insensitivity syndrome. So even if one word changes, answer changes. Okay, is this understood to all of you? Yes. Moving on. Chalo, now tell me the diagnosis again, because primary amenorrhea short, I got 3 questions back to back on this. Anybody tell me the answer? I want the diagnosis. Primary amenorrhea, short stature, shield shaped chest. तो ये किसका features है? Yes sir, these are features of Turner's syndrome. Turner's syndrome is short stature. What else happens? Short stature, shield shaped chest, wide carrying angle. Yes. So this, my dear student, is your Turner's syndrome. And in Turner's syndrome, do we have absent uterus? No, sir. Just now I told you. And normal ovary? No. Here, sir, do we have absent uterus? No. Do you have undescended testes? That is with which one? That is with androgen insensitivity. Okay. Yes, sir. We have got streak ovaries, but do we have absent uterus? No. Very good, all of you. B is the answer. So streak ovaries with hypoplastic uterus. Okay, so difficult virgin. There's a virgin MCQ. Virgin MCQ का मतलब क्या है? MCQ is not asked till now. Virgin MCQ is my specialty, my terminology. MCQ is not asked till now in the exam, but will come in the future for sure. It's coined by me as virgin MCQ. Okay, yes. Now, short again, new pattern. So please understand this. On my YouTube channel, there's a new pattern MCQ video. Dekh lo. New pattern are coming. Student get confused. What is this? Okay, match the column. Turner syndrome, all of you know 45XO. So 1A. So 1A, 1A. So do answer rule out. One is not C and this. Now, RMKH, my dear student, Mullerian agenesis is proper girl, 46XX. So 2C, yes. And androgen insensitivity to ladka hai, boy. I told you undescended, it's a boy, okay? So androgen insensitivity is a boy, which is 3B. And Klinefelter, you all know 47XXY. Very good. B is the answer. 2 is not B. Okay. So this is wrong. Okay. 3 is not C. Okay. Is this understood to all of you? So whenever you get match the column, don't make a mistake. Okay. Whenever you get a MCQ, you don't make a mistake in this. Just match the column and you will get it. Okay. Yes. Now coming to yes. All are screening tests done in the second trimester for aneuploidy. Aneuploidy matlab trisomy 21 except anybody? Anybody? Yes. Chalo. So now please, yes. Now can you tell me what are those screening tests? Yes, sir. All the remember whether it's a dual marker test, triple marker test, quadruple marker test. Now can you tell me how is this test done? How is the test done? How are this double marker, triple marker, quadruple marker test done? Anybody? With what is the sample? What is the sample for this testing? Any idea? Whether it is amniocentesis, CVS, what? How to do this double, triple mark? What is the anybody? If I tell you, is it amniocentesis, chorionic villus sampling, fetal blood? How is this? How is this triple marker, double marker, triple marker test done? Yes. All of you wrong. Clean bold, dandy gul. Please understand this. I do not know where the student has removed this kachara concept. Remove this kachara concept, put it in the dustbin. All wrong. All of you wrong. Clean bold. My dear student, the double marker, triple marker, and your quadruple marker test are all done on maternal serum, mother's blood. It is a simple blood test. Clap, clap, clap. Is it clear? Talk OG in the chat box. Okay, it is a simple blood test and on maternal serum I will detect double, triple, quadruple and they are only screening test. Please understand my dear student that amnio-CVS, what all of you told me is the confirmatory test. ओके इज इट क्लियर? यस बेटा ये तो बिगिनिंग है सिनिस्टरानी। ओके बेटा अभी ये तो पिक्चर अभी बाकी है। ऐसे जब आप लेक्चर सुनोगे मेरा तो और कितना नॉलेज मिलेगा। ओके जस्ट इमेजिन इफ दिस 1 आवर, इफ दिस लेक्चर टिल नाउ अभी 1 आवर हुआ, इतना नॉलेज मिला है, एंड यू इमेजिन लिसन टू 90 मिनट्स एवरी डे फॉर 10 days. Okay, yes. So double marker test is done in the first trimester. I'm writing T1. And triple marker, quadruple marker is done between 16 to 18 weeks in the second trimester. Second trimester is this. Thank you, Dr. Stark. Thank you. Love you for that. Okay. Okay. So double marker test, triple marker test are all screening tests and done in metal serum. Please, for God's sake, remember कि जो ये है the amnio and CVS, amniocentesis and chorionic villus sampling are the confirmatory test. There is a difference between screening and confirmatory. Okay, is it clear? Yes. So in the triple marker, we use HCG, alpha fetoprotein and unconjugated estriol. Very good, estriol. And quadruple marker may we add inhibin. Inhibin is in the fourth. But sir, the dual marker test is the answer over here, PAP A, because the question is all are done in second trimester except. Is it clear to all of you? All are done in the second trimester. So HCG, alpha fetoprotein inhibin And dual marker test ka component is PAP-A. PAP-A is what? So dual marker is PAP. It is HCG also. PAPPA. PAP-A and HCG. This is your combination. Okay. Okay. So PAP-A is what? Again, full form. Pregnancy associated plasma protein A. Okay, pregnancy associated plasma protein A, and it is, what happens to the value, anybody? Yes, it is going to be lower than normal. So PAP A, my dear student, is done in the first trimester. Okay, PAP A is done in the first trimester. Decree, yes. So HCG, yes, sir. HCG is both. Sir, alpha fetoprotein inhibin is clearly only. HCG is done in both. It is done in, it's a part of both. HCG is a part of both, matlab it's a part of double marker as well as triple and quadruple marker. Okay, so HCG is done in both the trimester. But PAP A is the answer clear cut, because PAP A is surely done only in the this. Okay. Yes. Now again, multiple this question. Don't get confused. स्टूडेंट का बहुत टेंशन आ जाता है इस सेटअप के क्वेश्चन देख के. चलो, व्हाट इज द क्वेश्चन? Okay, indication and prerequisites for delivery with ventus. Ventus is vacuum. Include which of the following? Okay, and then 4 statements are given and choose the correct code given below. Okay, so now please pay attention. Okay, for this instrumental delivery, what are the indications? So if it's a prolonged second stage, okay, prolonged second stage, then prolonged second stage matlab mother is pushing, or if I want to cut short second stage. No, but I will give you, don't worry. For our Ronak, you WhatsApp me, you know our system, you WhatsApp me for all those who are registered. Okay, yes, very good. Okay, so prolonged second stage is going to be there. Beta here both MCQ discussion के साथ proper revision ही हो रहा है. Okay, Asad Siddiq, proper revision हो रहा है MCQ discussion के side by side. Okay, prolonged second stage, or you want to cut short second stage. Anybody? When to do, when, what is the meaning of cut short second stage? Cut short second stage in which condition? Yes, where I don't want the mother to push too much. Like example, heart disease. I don't want her to जोर लगाने का. So like example in heart disease patient, you want to cut short second stage. Or if there is fetal distress, patient says, doctor, a baby heart rate is dropping down. And third, yeah, cancer, okay. And third is your fetal distress के साथ. But oncology MCQ is there. Piyush Sharma, oncology MCQ is also there on my YouTube. You can go, okay. And third is maternal exhaustion. Mother is exhausted. They say, okay, doctor, now I cannot push, I am tired. Okay, so these are my indications for forceps or vacuum. But my dear student, please understand this. Yeah, okay, the pelvis should be adequate. Whenever I apply any instrument, the pelvis should be adequate. There should be no cephalopelvic disproportion. Then only I can apply the instrument. And the most important is, my dear student, when it is vacuum, prematurity is the absolute contraindication. Okay, prematurity is the absolute contraindication. Why? Because, sir, if in a preterm baby I apply vacuum, there is more risk of intraventricular hemorrhage. Okay, प्री मेच्योरिटी में वैक्यूम नहीं लगाना है. इज दिस अंडरस्टूड टू ऑल ऑफ यू? फोर्सेप्स आप लगा सकते हो. सो नाउ सी न्यू पैटर्न एमसीक्यू, ऑल दोज हु जॉइन इन नाउ, वेरी इंपॉर्टेंट. सो डिले इन द सेकंड स्टेज, यस लगा सकते हैं. नॉन रीअश्योरिंग फीटल हार्ट रेट, फीटल डिस्ट्रेस, यस. एंड ऑफ कोर्स वर्टेक्स होना चाहिए. व्हाई? बिकॉज इफ इट्स फेस, एनीबॉडी, इफ इट्स अ फेस प्रेजेंटेशन, आई अप्लाई वैक्यूम, क्या होगा? आई बॉल्स विल पॉप आउट, आंख बाहर आ जाएगा. सिमिलरली बेबी का बम के ऊपर ब्रीच में नहीं लगा सकते. सो क्लैप इफ यू फील हैप्पी. अगेन वी फॉर वैक्यूम, वी फॉर वर्टेक्स. सो वैक्यूम is only for vertex presentation. 3 is wrong. Gestational age less than 34 weeks. So 3 should not be there. 3 जिसमें है, you will rule out. Wrong, wrong, wrong. Is this clear? And therefore, what is our answer? Okay. Okay, 1, 2 and 4. Don't worry, Dr. Stark, just giving you in 2 minutes. Okay, information. Okay, 1, 2. Is it clear to all of you? 1 may, yes, I can apply. 2 may I can apply, and 4. It's a question is both indication as well as prerequisite. Okay. Okay, is this clear to all of you? Can I get 10 thumbs up? So premature 3 jahan pe hai, because gestational age than 34 is a absolute contraindication for vacuum. So 3 out kar do. Wherever you see 3, cut it, cut it, cut it. And therefore ye bhi wrong, ye bhi wrong, ye bhi wrong. Answer is 1 to 4. So pelvis should be adequate, and there should be vertex presentation in vacuum. Forceps can be applied on face, vacuum nahi. And gestational age should be, if it's less than 34 weeks, then you don't apply vacuum, risk of intraventricular hemorrhage. Okay, now again a new pattern. So all this new pattern MCQs, arrange. What is this? AMTSL, active management third stage labor, in sequence, in the correct sequence. Please arrange this AMTSL. So what is this AMTSL? Any idea? AMTSL is for prevention of PPH. AMTSL is for preventing of PPH or decreasing the risk of PPH. Now, always remember here how much we give. Yes, active management third stage labor. Okay. Now please pay attention. Please pay attention. No, but a uterine massage can still. Okay. So please pay attention. Point number one. The important point is that I need to rule out twins. Why rule out twins? Matlab ke make sure that there is no babies left inside the uterus. Can you tell me why? Because sir, suppose there are twins. All of you look on the board. Suppose there is twins and only one baby is delivered, one baby is out, and still one baby is inside the uterus. What will happen? Because sir, in AMTSL we are giving mainly oxytocin 10 units. 10 units is a very high dose. Because sir, in AMTSL my logic is I want to make both the upper segment and lower segment contract. So what will happen? Anybody? If the baby is inside the uterus and I give 10 units oxytocin, what can happen? Yes, fetal distress. That second, this big such a big rupture uterus. Okay, yes, uterus will contract vigorously. Very good. And this baby can have fetal distress, or the baby can die and rupture. Yes, this baby, and you should be double. You will have to go to jail. Sir, क्यों jail? Because double murder, fetal distress, the baby can die, even, and risk of rupture uterus also is there. Okay, if there's a baby still inside the uterus. Is it clear to all of you? And therefore, always first is check for twin pregnancy. Okay, so A will come first, A will come first, A will come first. उसके बाद we will give 10 units oxytocin IM. A के बाद C, A के बाद C. Okay, is it clear to all of you? So in this, the basically, so make sure there is no more. So what to do if it's twins? Sir, if it is twins, no problem. All of you look on the board. Sir, in twins, I can do AMTSL. Twins may deliver first baby, Write down. Do not do AMTSL now. Very important. Yes. But gestational sac nahi, sac, yes, second pura. Then deliver the second baby, and yes, now I can do AMTSL. Clap if you have learned something new. Okay, so yes sir, in twins we will do AMTSL, but after delivery of both the babies. Okay, so make sure that there is twins, you will check. This is followed by 10 units oxytocin IM. This is followed by control cord traction, so be, and lastly uterine massage after placental delivery. Okay, only after placental delivery. And can you tell me one more bonus MCQ? What is another name for control cord traction? So A के बाद C, then B and D. A के बाद B नहीं है directly, that is wrong. A and D, yes. Is it clear? So A is the answer. Is this clear to all of you? Can I get 10 thumbs up? Are all of you following me? समझ में आ रहा है बच्चा लोग? Yes. Are you enjoying the session? OG एक बार in the chat box. If everybody is understanding and enjoying the session. Okay, yes, very good. Sir, control cord traction, another name is brand. BRANDT, brand Andrews maneuver. Okay, brand Andrews maneuver. कर रहा है. Okay, is it clear to all of you? Yes. Okay, so before both of students ask me, just a minute. Yes, so quickly 10 seconds students bachcha log quickly start following me on Insta. Every day super information we are putting out on Insta, superb reels, very helpful, only important, no time pass, no dance, kuch nahi, all education reels, all MCQ discussion, all strategy, and YouTube pe lots of videos are there. And this same, many of you asking where the PDF will be available. Okay, by tomorrow morning or today evening the PDF will be available on my Telegram channel. And this is what it is, my dear student. Quickly get in touch with me on phone and WhatsApp. OGGuru app, download the app now. So many students, I repeat, because 30 to 35 MCQs are coming every year in OBGY, and I get student, and that's fine if it's Insta bando, okay, I get students who are stuck up. Students are stuck up at the score of 135, 140 for 3344 attempts. Then they enroll in my OBGY, and sir, OBGY ne hi beda par kara diya. Why? Because minimum, I can assure you, if with your current knowledge you are getting 10, 11, 12 MCQs correct, after my this session the score is going to jump up to 27, 28, 29. 15 marks more minimum, 15 marks more you will get. And that is this shortcut revision, fastest ever way for FMG. Quickly download, and this is 9 live classes starting from 8th of December. Okay, so जो लोग भी पूछ रहे थे, this is for this. Okay, live classes will be starting in the evening. Whole day study your other subjects. Whole day study other subjects. OBGY मेरे पे छोड़ दो. OGGuru है ना. Just in the night, come night मतलब 7 o'clock, 8 o'clock, 9 o'clock timing, 9 classes, 90 minutes. Okay. Question answer, rapid revision, all MCQs, PYQs, IBQs. And my dear student, this PYQ is not only of FMG, even NEET PG PYQs also will be done. That is very important. FMG to karenge, but even NEET PG PYQs will also be covered. That is very important for all of you. Okay. Is it clear to all of you? And all live sessions will be there, and recording will also be available, and beautiful notes also you're going to get. I'll show you the notes also. Okay, so this is the shortcut revision. Okay, yeah, I'm coming to that. Okay, yes, I'll tell that also. Okay, so all this thing. Okay, so this is, please understand this, launch 30 is the coupon for all the new students, only 849. For all our existing students, you're going to get it only in 214. Okay, is it clear to all of you? Okay. So all those who have already taken my packages, don't worry, we are not going to charge you again. Just a basic, simple 10-day, all 10-day classes you are going to get only in 25 rupees per day. That is the special coupon OG family. Yes, better, so I'll tell you. Okay, we'll do that. WhatsApp. Okay, is it clear to all of you? So more information about this, directly WhatsApp me if you have. Okay, and then we'll get in touch with you. Okay, yes, chalo. Which of the following is not true? Now tell me. Not true for trisomy 21 screening. Yeah, so beta, there's no specific answer. They should specify. Okay, ACOG says clear. You are correct. 6 centimeter. WHO का 5 है. You are correct. There should be a clear cut. They should specify in this. Okay, on the home page itself we have covered shortcut also, and FMG course के अंदर भी है. FMG course, you open up the first course itself is shortcut line. Okay, yes. Yes. So all of you please pay attention. In the screening test, alpha fetoprotein, yes, we call it as maternal serum alpha fetoprotein, is lower than normal. PAP-A is also lower than normal. And NT scan, I'm going to tell you what is this increase in NT. This is a screening with ultrasonography. Yes, anybody? Yes, I just now told you HCG is going to be higher than normal. Yes, HCG is higher than normal, and therefore the answer. NT scan, my dear student, is a nuchal translucency scan. All of you look on the board. This is the baby, nose, mouth, okay, and eyes, and then like this is the baby, okay, and here is the umbilical cord. So you are supposed to zoom this part, and every baby at the nape of the neck, there is a translucent space. NT matlab nuchal translucency, okay, and up to, very good, up to 3 millimeter is considered normal, okay. NT more than 3 millimeter is the unknown. What is it, beta? Unknown, can you repeat your question? Your question went up. Same, what is beta? Unknown. Beta, breast cancer, I can't teach. Breast cancer, your surgery teacher has to teach. Yes. Yeah. Cystic hygroma also is there. Okay. So, yes. Okay. So, yeah. Okay. Is it clear to all of you? So, nuchal translucency is increased. And one more important, so NT is done on USG when you do also. And one more nowadays, we remember this, we also do nasal bone, NB. So therefore it is called as NBNT scan. Okay, NBNT scan. Okay, is it clear to all of you? Is it clear to all of you? Yes. Okay. So yes, so PDF will be available on the Telegram. Okay, by tomorrow morning. And this is what I've told you. Get in touch. Let's not make disturb other students here right now. Get in touch with me on phone and WhatsApp on this number. All information will be given to you. Just download the OGGuru app, and in the FMG course you'll see this shortcut. 8th December. 8th December we are starting. We'll be finishing by 16th or 17th December. All 9 sessions. Your OBGY score is going to jump up from 15 to 30. From 15, at least marks more you should get. Okay, I'm not showing you the students review. All that you can check later on, sir. You are this OBGY ne bacha liya, sir. Same thing will happen with you. And so the score, students were stuck up at 140, they are crossing 150. Okay, yes, as per the latest criteria, modified BPP includes what? Now BPP is whose score is, it's a test for fetal well-being. It is called as Manning's score or Manning's criteria. Okay, and remember, my dear student, this latest word is just to confuse you. Latest कुछ नहीं है, same ही है. Okay, BPP, anybody? Total BPP, in complete BPP there are 5 components. Okay, 5. What are the 5? NST is a part of it. NST, fetal tone, fetal movements, fetal breathing movements, and amniotic fluid. So it is time consuming. It is time consuming when I do all these things. Okay. And this fetal tone, FM is fetal movements. Fetal movements. And BM is breathing movements. Okay. So to save time, I do only NST plus AFI. amniotic fluid index. That is the answer to save time, NST and AFR. Now anybody tell me please, who will count the fetal movements in BPP? When we are doing BPP, in BPP, who will count the fetal movements? Yes, anybody? Mother, father, neighbor, intern, doctor. Who will count the fetal movements? Okay. Mother will count the fetal movement, father will count, neighbor will count, or the intern doctor will count. Who will count? Okay. Clean, bold, dandigul. Neighbor, first of all, neighbor should not count anything. Okay, if neighbor is counting, there's a problem. So neighbor को कुछ count नहीं करना है. Not father, not mother, and not intern. Intern has to study for NEET, PG and FMGE exam. Please understand this wrong. That mother, clean, see concept. That's why my lectures, hashtag crystal clear concepts. OGGuru, yes, very good. Nippon VB4SG, very good. Sinister Rani, very good. क्या बात. Okay, so beta log, that mother counts the movement is called as FKC, fetal kick count. In fetal kick count, the mother is counting the movements. In BPP, we have to do ultrasonography. Ultrasonography is done for 30 minutes. So very good. The radiologist will check for the fetal movement. Is this understood to all of you? Okay. CTG is different. CTG is your cardiotocography done in liver. Clap if you have learned something new. ठोको ताली, तालियां बजती रहनी चाहिए. So mother fetal kick count is not a part of, that's a separate thing. Is it clear to all of you? Okay. Is this understood to all of you? Okay, is this clear to all of you? Yes. Okay, so please understand this, that sir, the sonologist or the radiologist will count the fetal movement. That is what is BPP. So remember, if they ask you what is required to do a BPP, sir, two machines. I require NST machine and ultrasonography is required to do BPP. For BPP, I require USG. USG has to be done for 30 minutes. Okay, USG into 30 minutes. Yes, earliest diagnosis of live pregnancy is yes. Now, when I say live pregnancy, anybody, why not serum beta HCG is not the answer? Why? Why urine pregnancy test? ये UPT क्या है? UPT is urine pregnancy test. We put the urine of the pregnant lady. 2 बूंद ऐसा आता है पिक्चर में. ओके, 2 अंदर फिर लाइन आता है. ओके, 2 बूंद खुशी के, 2 बूंद जवानी के हम डालते हैं और फिर लाइन आता है. 1 लाइन, 2 लाइन, कभी खुशी कभी गम. Why कभी खुशी कभी गम? Because sir, if it's a planned pregnancy, very good, खुशी. If it's an unplanned pregnancy, tension, stress. Okay, so urine pregnancy is detecting only urinary HCG, and similarly serum beta HCG is only detecting pregnancy. It is the hormone. It is to earliest detect pregnancy. It is to earliest detect pregnancy. No, Nipun, wrong. TVS is not positive before beta HCG. Wrong concept. Wrong. Okay. Why this is the answer? Yes, beta HCG is to earliest detect pregnancy. It is positive even before missed periods. It is positive even before missed periods. But look at the question. हमको find out करना है live pregnancy. Baby should tell you जिंदा है. देखो पठान, शाहरुख खान बता बोलता ना, पठान जिंदा है. ओके सो पठान जिंदा है बच्चा ओके सो लाइव प्रेगनेंसी के लिए आई शुड नो fetal heartbeat, yes or no? Thak 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 thak, fetal heart. And that, my dear student, is by transvaginal sonography, where I demonstrate fetal cardiac activity as early as 6 weeks. मॉडर्न मशीन में 6 weeks या इवन अप टू 5 weeks 5 days. Is this understood to all of you? Clap 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 if you have learned something new. Okay, but if I now variation, चलो अगर एक वेरिएशन बता दिया क्वेश्चन का, and if I make this question, if I remove this word live, now what is the answer? Now what is the answer? Earliest diagnosis of pregnancy is by. तो क्या आंसर होगा? Yes sir, now it is D, serum B, because UPT is positive only after missed periods. Excellent. I can't take everybody. I'm very good. Tanya, Neeraj. Okay, and all of you please participate. Right, wrong does not matter. Only after me. And please share this video with all your friends and colleagues as much as you can share. Okay. Is this understood to all of you? Okay, so in UPT and HCG is only for, yes, you cannot comment whether the, just suppose if I tell you HCG 5,000, 10,000, how can I know baby live, not live, dead baby? Yes, for live pregnancy, sir, for live so if it's live is not there, for live pregnancy, I have to check the baby ka fetal heartbeat. Okay, heartbeat checkup, heartbeat tuck 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 tuck, that is called as fetal cardiac activity, and transvaginal sonography is the answer. Is this understood to all of you? No, unknown HG6 beta, UPT is only positive after missed periods. Okay, HCG is positive even before missed periods. Okay, yes. Image based MCQ, virgin question, never ever asked. Can you tell me what is this image showing you and what does it contain? What does it contain? Yes, sir, this is, what is it? First, tell the name. First name batao. Yes, sir, this is the brand name Mirena. Mirena is a brand name also called as levonorgestrel intrauterine device. Levonorgestrel intrauterine device. And totally how much hormone and how much per day? Two separate MCQs, majority students clean bold. So total it contains 52 milligram. Total it contains 52 milligram of levonorgestrel, and 20 microgram per day is released in the uterine cavity. Okay, so don't get confused. Okay, and therefore all of you, it does not contain estradiol progesterone, yes, but 20 milligram nahi hai, LNG 52 milligram. What content and quantity? Okay, and if they ask you how much is released per day, 20 microgram per day. And can you tell me, yes, the lifespan is for 5 years, very low failure rate. Can all of you tell me what are the other benefits of this? What are the non-contraceptive benefits of Mirena? What are the uses of Mirena? Anybody, can you tell me? Where do we use Mirena? Other than birth control. Not regular periods. No. It will not. In fact, what happens to the periods? No, protect, wrong. Protects against endometrial cancer, not ovarian. Chalo, tell me where. Okay, very good. Endometriosis, very good. What else? Just tell me what happens to periods. Very good, adenomas. Yes. So please pay attention, my dear student, continuously, because we are giving progesterone. Progesterone is released in the cavity. It counteracts estrogen. It does not allow the endometrium lining to grow. Okay. It does not allow the endometrium lining to grow. So all of you look on the board. Okay, I will shave. I will shave only if the beard is growing. If the beard is not growing only, Tiger Shroff, तो क्या shave करेगा? Okay, so when Tiger Shroff came many years back, he didn't have beard. Now he has done recently beard transplant, all that. Okay, तो अभी beard है, लेकिन पहले उसको बिल्कुल beard नहीं आता था. तो same logic कि sir, only if the lining grows, then it sheds off its menses. Myrina, the lining remains very, very thin. Yes, very good, unknown. So mainly the lining is going to be remain, lining is become very, very thin, and the main use is heavy menstrual bleeding. We are going to use it in patients of, so menses will become scanty. Its purpose, its role is to induce amenorrhea. Induce amenorrhea in the patient. Okay, either the mens will become very scanty or little spotting. So mainly, my dear student, it is used for patients of menorrhagia, adenomyosis, endometriosis. All these cases we can use it, pain, and mainly dysmenorrhea and menorrhagia. Okay, and lastly, it also protects against prevention of endometrial hyperplasia, endometrial cancer. ये सब के against वो less. Okay, is this clear to all of you? Clap if you have learned something new on a Saturday afternoon. Okay, so Myrina or LNGIOD is used in management of menorrhagia, dysmenorrhea. Yes. Now, what is this? What is the ideal time to perform the NT scan? Very important. Yes, surgical TND we are doing. Sorry, we are doing TND from 8th of December. Okay, 8th December onwards. Very good. The 11 to 13 weeks is the time when I do the NT scan. And nowadays we know it's a marker for Down syndrome, and it is also called as NBNT scan. Can you tell me what is NBNT called? Nasal bone and NT, nuchal translucency. Why? Because one of the features, absent nasal bone. Okay, in Down syndrome the nasal bone is absent. Okay, trisomy 21, there is absent nasal bone. So you also call it an NT will be more. And you know what happens in trisomy 21? Increase in NT. Okay, yes, NT is going to be more. Very important short MCQ. When I have a patient who has a septate uterus, which of the following is used in the management of this condition? ABCD. So please understand this. Lifelong you will not forget, my dear student. Okay, sir, laparoscopy, hysteroscopy are different. Sir, in laparoscopy, we put in a telescope from above. Through the anterior abdominal wall, I will put in a telescope, and it is a terrace view from above. From above, we will be seeing the fallopian tube, uterus, uterosacral ligament, pouch of Douglas, ovary, all that. That is laparoscopy. But my dear student, from above, when you look at the uterus, you cannot see the inside. Hysteroscopy is the classroom. Inside the classroom view, it is to see the cavity of the uterus. Hysteroscopy I will put inside the, through the cervix, through the vagina, to visualize the cavity of the uterus. And no, not lap. Okay. And my dear student, septum is always within the cavity. Here is the septum, like this. Septum is always projecting, septum is always projecting inside the cavity. Is it clear to all of you? Septum is like this. It's a projection which is inside, and therefore I will not do laparoscopy, not laparotomy. The answer is yes. Hysteroscopy, septoplasty, or septal resection. So these all are concept based question, which if you don't know the meaning, you can never get it right. And through the hysteroscope, we will go and we can cut. You can cut the septum like this. Okay, there's a scissors and you start cutting. You can cut the septum. Is this understood to all of you like this? Okay. Like this, see, like this, we are cutting, and you keep on cutting the septum and make the cavity normal. Yeah, septate uterus is a Mullerian anomaly. Okay, beta. Neeraj Singh, septate uterus is a Mullerian anomaly where the septum is a parda. Okay, it is a septum which is projecting into the cavity. It will lead to infertility, repeated miscarriages, and all that. So basically septum ke liye you require hysteroscopy and not laparoscopy. Is this understood to all of you? Moving on. Hysteroscopy, chalo, very important. Same logic. Hysteroscopy is indicated in all of the following except. So what is absolutely short MCQ? Anybody? I told you. What is no, laparochromo is different, beta. Okay, sir, what is Asherman syndrome? Sir, intrauterine adhesions. All of you look on the board. Sir, intrauterine adhesion is our Asherman syndrome. Similarly, so here, yes, I can put a telescope. And what do? We can do again a PYQ. It's again a PYQ. We do hysteroscopic adhesiolize. All of you look on the board. See, देखो surgery हो रहा है. Cut. And cavity became normal. So for Asherman syndrome, you require hysteroscopy. Similarly, sir, if there's any fibroid within the cavity or there is any polyp, all these are going to cause menorrhagia. Fibroid polyp, menorrhagia, fibroid polyp, and similarly all these things will also lead to infertility. This fibroid polyp, septum. Okay, so just remember all these four conditions: fibroid polyp, intrauterine adhesions, and septum. This will require my hysteroscopy. Is this understood to all of you? Sir, adenomyosis is what? Presence of glands. There are glands within. You require ultrasonography. Okay. And your radiology teacher will teach you Venetian blind appearance, salt and pepper appearance. Adenomyosis, all of you look on the board, it's like this. So in adenomyosis, there are glands, there are cystic spaces within the myometrium. Okay, adenomyosis bolne do. Yeah, even if the option is endometriosis also. Sir, endometriosis requires laparoscopy. Laparoscopy can check endometriosis, because in endometriosis you can see a chocolate cyst and we see all the we are seeing the pelvis and we see that matchstick burnt spots, powder burnt spots, and all the spots. Okay, blueberry lesion, red, all that. Okay, all that we discuss in several separate lectures. Okay, so endometriosis के सब lesions होते हैं, blue color, black color, and chocolate cyst. So endometriosis you require to do laparoscopy. There could be adhesions between the tube. Okay, और क्या होता है endometriosis में? Anybody? Blue color lesion, isn't it? Blueberry, red raspberry, ऐसे blue lesions दिखते हैं, blue कलर के lesions, उसको blueberry lesion, blue lesion बोलते हैं, blue, black, red. Yes, revision already discussed. As per the latest MTP Act, MTP is now allowed till 24 weeks of gestation, but this 24 weeks is for rape, sexual assault victim, and chromosomal or anomaly in the baby. Please write down for failure of contraception still only till up to 20. Failure of contraception still only up to 20 weeks. Okay, is this understood to all of you? 24 weeks is allowed now, and this. Okay, yes, is this clear to all of you? Yes, normal जैसा कुछ नहीं for failure of contraception. Okay, very important. Definitely, beta. Yes, we'll discuss that. Okay, Patel meet. Yes, you tell me, message me. Yes, you can. Live class is just for revision. Okay, yes. A patient has 45 days amenorrhea, wants MTP. What will you do for her? A, B, C, D. Okay, so this is again a very important MCQ. All of you look on the board. This is going to be a combi kit. Combi kit. एक single tablet होगा and 4 tablets like this. Now, which is to be given first? Anybody? Which drug do I give first? Total confusion. Sir, Mifi Mizo. So again, clap if you feel happy. Thokotali. Main hu na. Sir, Mifepristone is given first. Why? Because F hai Mifi mein there is F, and in first also there is F. Clap if you feel happy. Okay. Yeah, you can join beta all over. You can just download the app beta. Unknown HGC, just download the app and you can join. All over the world students are joining. Okay, even if you're outside India, no problem. Okay, specifically for the Jan FMG. Okay, is it clear? Clap. So Mifi is F. In Mifi the word comes F. So Meso is given first, and this is a single tablet of 200 milligrams. Okay, and after 48 hours, so it is day 1, day 3, I will give Meso. Again, easy to remember, sir. In Meso there is S and second is again S. So Meso is the second drug. Is this understood? Lifelong you will not forget. Okay, sir, Mifi देना है first because Mifi में है F. Meso देना है second after 40. Okay, and Meso is PGE1 mesoprostol. Each tablet is 200 microgram, and you can see 4 tablets are there, so 800 microgram is given. Is this understood to all of you? Yes, either vaginally or orally or sublingually. And Mifi is a single tablet of 200 milligrams. So don't get, now tell me the answer. So now see, why not option A? Why option A is not the answer? Student directly, yes sir, Mifepristone 200, misoprostol 800. Isn't first the answer? Wrong, clean bold, because units, yes, unit, I have interchange. Mifi is not in microgram and Meso is not in milligram. So first is wrong. You don't give Meso first, you don't give methotrexate. Okay, similarly Meso is not given first. The doses are correct, लेकिन उल्टा पुल्टा होगा. Yes, the answer is very good. Option C, Mifepristone 200 milligram and misoprostol 800 milligram after 800 microgram after 40 days. Short MCQ is coming. Shower hearts. hearts and love emoji, and claps and OG in the chat box. The short MCQ है 5 star. Please don't make it mistake. is short आने वाला है. Okay, is this understood? So just remember this complicate. Now what is this device? ये एक instrument है. This instrument least likely, this is least likely to be used for what? Okay, yes. So sir, this, if you see, this instrument is like this. Okay, instrument is like this and like this, thoda sa. This is a uterine sound. Yes, this instrument is called a uterus ka sound, uterine sound, to measure the uterocervical length. Okay, so in all places, all of you look on the board, in all places where I want to put something inside the uterus. So in dilatation, why? Because this can cause perforation. That means, suppose I'm just giving you an example. Okay, sir, UCL is only this much. And if I put my instrument more up inside, then I can cause perforation. Okay. So wherever, like I'm putting in a dilator, I'm putting in a suction cannula. So dilatation and curettage, dilatation evacuation or suction evacuation, IUCD insertion, all these cases, we need a uterine sound to measure the uterocervical length. Is this understood to all of you? Removal. Yes, sir. Removal of IUCD mein, you are, don't worry. Removing IUCD is just with the help of the artery forceps, isn't it? The threads are visible. This is the uterus. This is the copper T. Threads are visible. So just catch these threads with a artery forceps and pull the copper T out. So for removing of IUCD, sound is not required. Sound matlab your uterine sound. This sound is not required. Is this understood to all of you? But all dilatation, curettage, suction evacuation, IUCD insertion, you need to sound the uterus. Sound also acts like a first dilator. Yeah, Manohar, IUCD hook, only the threads are curled up. If the threads are curled up, then we might want to use IUCD hook. Okay, so uterine sound is to measure the uterocervical length, so that I will not, and sound also acts like the first dilator. First the sound, so always sound the uterus first and then put in the subsequent dilators. Okay, is this understood? Now again a PYQ. We have got a sonography. We have got a sonography where ads are coming. Yes, sorry, the ads are not under my control, so you are getting ads. You might see some ads in between, but that's not, I can't help it. Okay, yes. So in the infertility treatment, yes, whenever ovulation induction agents are used, specifically which agents? Sir, HMG and HCG, human chorionic gonadotropin, then HCG. Okay, and this is a big ovary and we are getting multiple big follicles. But actually, along with this, what should also be seen? Anybody? Only this is not enough actually. In the exam, this question came, surgery में clomiphene के साथ नहीं होता है. Very rarely with clomiphene, mainly with HMG gonadotropins. Okay, yeah, if you use recombinant FSH and HCG. So remember this. Along with this, we should also actually see ascites. Actually, ascites has to be there. There has to be free fluid in the pelvis also. Yes, very good, Rani. Okay, but that most of the time they are not showing in the exam. Okay, but still the answer is OHSS, ovarian hyperstimulation syndrome. And now why is it not PCOS? How to differentiate? Please pay attention, all of you. Sir, in PCOS, I already showed you there are multiple small follicles arranged in the periphery. So chota follicles arranged in the periphery hoga, and here you will get all big follicle. That's the difference in the exam, and they will also come in the center. Okay, so this is small small follicles and in the periphery. That is PCOS. Okay, and here they are all big follicles. They will come right in the center, plus actually ascites should also be there for us to see. Okay, is this clear to all of you? Yes. Grayish white discharge whiff test, sure short MCQ. whiff test किस में होता है? So whiff test and bacterial vaginosis or Gardnerella infection. Very good. And metronidazole is the drug of choice. Okay, in your bacterial vaginosis as well as in trichomoniasis. Okay, fluconazole is given mainly for our fungal infections. Okay, fungal infection. Okay, locally clotrimazole or fungal fluconazole can be given. Is this understood to all of you? Yes. So very simple one-liner. And anybody, what is this positive whiff test? What is done? Any idea? Any idea what is done in positive whiff test? Sir, vaginal secretions are taken. You take the vaginal secretions and to this we add 10% KOH and we get a fishy odor. Because fishy odor because of release of amines. This is the whiff test. Okay, is this understood to all of you? Yes. Now tell me again a clinical case. Yes, but all these, some of the questions are majority are made by me, some are PYQ, some are virgin MCQ, some are the most important. That is why this is whole MVP. Most important and many are already PYQs. Okay, FMGE M71. So they are PYQs. You will be seeing it in the this and like this question are only going to come in the exam. Now, first of all, very this now this is a virgin MCQ. This has come once in the past in the NEET PG. Okay, so they are this one of all this also. Now, can you tell me PYQs of NEET PG and FMG? Now, can you tell me, so patient had aborted at 11 weeks, there was incomplete abortion, whatever, she underwent a curettage, afterwards she has not had got her periods, FSH is 5. Now, please tell me first of all, whether this FSH 5, is it, okay, whether this FSH 5, is it normal, less or more? Is this FSH 5 low, normal, high, very high? Was it, what is it? Okay, what is it? First tell me whether ye FSH 5 is what? Is it less? No, FSH 5 is normal. Okay, so when you have, because, and I'll show you the variation, how the answer will change. Okay, how the answer will change. Okay, if the FSH, when they want to tell you, remember FSH for 5 to 10, okay, this is just a rough thing, 5 to 10 or sometimes even they tell 3 to 10, you consider it as normal in the exam. Okay, normal. When they want to make it low, when they want to give you low FSH, they will not give you borderline 4, 3. No, they will give you very low, like 0.1, 0.2, basically less than 1. Less than 1 is low. And when they will want to give you high, then directly they will give you like this, 20, 30, 40 is high FSH. Okay, yes. Okay, is this clear to all of you? So when the FSH is 0.5, point thing, anything less than 1, we consider it low. Between 5 to 10 is roughly normal. And if they tell you 30, 40, even 15, 20, 30, 40, that is high. And why this is important, all of you? Because master-servant relationship. Okay, now tell me this. Pituitary is the master, ovary is the servant, isn't it? So suppose there's a master problem. Can you tell me if there's a problem with the hypothalamus or pituitary? Hypothalamus, pituitary. What will happen to the FSH? Yes. Anybody? Yes, sir. If the master himself is sleeping, FSH is going to be very, very low, isn't it? And my dear student, like if you are not studying, then आपके parents क्या बोलेंगे? Or if your servant is not working, they will say, "Baba, काम करो, काम करो, काम करो," isn't it? So whenever it is a ovarian problem or ovarian fault, the master will shout more loudly. And when it's a ovarian failure, in ovarian failure, FSH is high. In hypothalamic pituitary failure, FSH is low. Is this clear to all of you? And if there is intrauterine adhesions and the fault is inside the uterus, then FSH normal, isn't it? Because fault is inside the uterus. So now if you see, sir, in ovarian failure, FSH is going to be high. In pituitary failure, FSH is going to be low. And this is the answer, intrauterine. Clap if you feel happy. Sir, intrauterine sine K, intrauterine sine K, FSH is normal. Why? Because the fault is inside the uterus. Master and ovary both are normal. So three variations. Now all of you tell me, suppose if this phi, I make it 0.5. Now tell me the answer. चलो एक MCQ पे 3 MCQ फ्री. Okay? अगर this FSH of phi, I make it 0.5. Now what is the answer? Clap, clap, clap. Absolutely. Hashtag crystal clear concepts. What my student get. Okay. Okay, sir. In pituitary failure, FSH will become 0.5. And if I make this phi ka 50, if I make this 50, then what is the answer? Yes, sir, FSH 50, matlab it is ovarian failure. Yes, this history of curettage already, okay. This underwent a check curettage is a clue in the history. Yes, sir. Sir, FSH 5 is normal. And we know, okay, sir, why do we get Asherman syndrome? Sir, excessive curettage. So, sir, because when there was this incomplete abortion, she underwent a check curettage and that could have been excessive. The doctor may have done excessive curettage, which leads to adhesions and fibrosis called as Asherman syndrome. Is this clear? Yes, hopefully. Okay. Yes. Okay. Yes. Now, further, yes, revision. चलो सुबह सिखाया, एक घंटा पहले सिखाया, again revision. Yes. Fothergill repair associated with all of the following complications except. So, sir, I told you Fothergill is the surgery for prolapse. It was a surgery for prolapse, which is hardly ever done nowadays. And in Fothergill, we were doing cervical amputation. Cervical amputation. Nowadays, hardly we are doing this, almost never done, because yes, sir, it can lead to cervical dystocia, it can lead to preterm labor. None, nahi, Tanya, wrong. None is not the answer. I told you, sir, what we will get? Sir, we will get cervical incompetence. And cervical incompetence will always lead to abortion in the second trimester. Yes. Mid-trimester, isn't it? What is the typical history? Sir, repeated painless mid-trimester abortion. Mid-trimester hota hai. Is it clear? So first is the answer. First nahi hoga. Is it clear? Thokotali. Second. So this one word, see how one word in the exam you can mark it wrong. Short again ye MCQ aane wala hai. Okay. Is it clear? So sir, they cause repeated painless mid-trimester. Okay. Most of the time it's a painless. Okay, crystal clear in the chat box. Yes. Now, ovarian torsion. Whenever it's a ovarian torsion, the next best investigation, what do we do? Yes. Remember this, my dear student, in torsion. Now, can you tell me one more MCQ? Which is the most common ovarian tumor to undergo torsion? Most common ovarian tumor for undergoing torsion. Dermoid cyst. Very good. So, dermoid cyst or a teratoma, dermoid or a teratoma is the most common ovarian tumor to undergo torsion. Keep this in mind. Now, please understand this. Okay, sir, suppose this is the pedicle and this is the tumor, and if it undergoes torsion, if it twists, acute abdomen, patient gets severe pain, vomiting, and acute abdomen, vomiting is also classical feature, and severe pain. And remember, color Doppler, very good. Color Doppler will check the blood flow anywhere where you want to check the blood flow, because sir, when the pedicle will be twisted, the blood flow is occluded, isn't it? Common sense. If you twist it, the blood flow gets occluded, and you will know, okay, uh, and you will come to know, okay, there is no, but MRI will not. For torsion, I have to do color Doppler. Color Doppler is the investigation of choice for torsion. Okay, whenever torsion is suspected, hysteroscopy is for the cavity. MRI CT scan will tell you how the mass is. Okay, how the mass, okay, mass is big, small, solid, irregular, regular. How is the mass looking like? But whether the flow, yes, the flow will be, if the flow is cut off or the flow is absent, then you know, okay, this has undergone torsion. Is this understood to all of you? Clap. Okay. Yes. Moving on. So very good. Yes. Very good. Short MCQ. Beta, immediate surgery. Dr. Strange, you have to go for immediate surgery. Whenever there's torsion, you do immediate surgery and detorsion. And if the necrosis part, you might have to even cut it off. Okay. Immediate surgery has to be done. Surgical management. Yes. Chalo. Now tell me the diagnosis, all of you. 28-year-old, 31 weeks only, so only 31 weeks, and complains of headache, blurring of vision, oliguria, BP 180, 110. The next line of treatment is, now, is she having convulsion? No, convulsions are not there. So if somebody says the diagnosis is eclampsia, wrong. Diagnosis is not eclampsia. Very good. Severe preeclampsia, because BP is 180, 110. But all of you remember, this patient is not only eclampsia, this is impending eclampsia. Impending eclampsia. Now, can you tell me why am I calling this impending eclampsia? Okay, is it clear to all of you? Yeah, thank you, Fruit Loop. Thank you. Yes, can you tell me why is it impending eclampsia? Because remember, they are called as premonitory symptoms. They are called as, what are the premonitory symptoms? All of you pay attention. Okay. OB, क्लू कैसे आ, OB easy है ना? ओके, मैं हूं ना. ओके, मैं हूं ना, जब ओजी गुरु है ना, तो OB easy है ना. Okay, clap. So how you know OB easy है ना? O is oliguria. Remember, I've given you the mnemonic. Okay, oliguria. B is blurring of vision. Okay, E is your epigastric pain. H is headache, and N is nausea, vomiting. Okay, is this understood to all of you? Is this understood to all of you? Oliguria, OB easy है ना? Okay, that's the mnemonic you will remember. All of you, yes. O oliguria, B blurring of vision, E easy का epigastric pain, H headache, N is your nausea vomiting. Okay. Okay, is it clear to all of you? Yes. Okay, so yeah, enough beta, fruit loop enough. Okay, no masti. Okay, yes, so OB easy है ना? Tocolytic. So whenever these symptoms are present, then the patient is going to be impending eclampsia. Okay, whenever you have a patient of preeclampsia with any of this premonitory symptom, it becomes your impending eclampsia. Now can you tell me what is to be done for impending eclampsia? Anybody? Yes. Now, in impending eclampsia, all of you look on the board. Those who want to wait and watch, they go to jail. Okay, where jail? Jail मतलब आपको जेल में डालेंगे. Because if in impending eclampsia you wait and watch, it's a crime. Because mother will die anytime the convulsion can come. So please understand this. Now, आपने हिंदी पिक्चर में देखा होगा, डॉक्टर comes out of the labor ward and says हम माँ और बच्चे में से किसी एक को बचा सकते हैं. Is it clear? एंड फिर कोई बोलेगा माँ को बचाओ, कोई बोलेगा बच्चे को बचाओ, साथ में इंडियन गवर्नमेंट टाइगर को बचाओ. ओके, बाजू में इंटर्न होगा, बोलेंगे टाइगर को बचाओ. ओके ओके बेटा, मेरे हाथ में नहीं है बेटा रोहित, आई कांट मेक द एड स्टॉप. ओके, सो प्लीज अंडरस्टैंड दिस कि ये जो ऑप्शन है कि माँ और बच्चे में से किसको बचाना है, दिस ऑप्शन इज नॉट इवन गिवन टू द रिलेटिव्स. आर यू गेटिंग माय पॉइंट? इट इज ऑलवेज मदर फर्स्ट. इन ऑब्स्टेट्रिक्स इट इज ऑलवेज मदर फर्स्ट. सो वेन एवर यू हैव impending eclampsia, whenever we have got impending eclampsia, please understand this, whatever may be the weeks, all of you, okay, whatever may be the weeks, let it be 24 weeks, let it be 26 weeks, let it be 28, let it be 32, you will have to go and do the delivery. Why delivery? Because the delivery is the definitive treatment. Is this understood to all of you? Yes, because mother is important. You save the mother, बाद में पीछे पूरा cricket team आ सकता है. So delivery has to be done. But when we do the delivery, before giving the delivery, doing the delivery, we also give magnesium sulfate. Anybody? Why? Why magnesium sulfate? Okay, why magnesium sulfate? Because sir, now has this patient got convulsion? No, it is still impending eclampsia. But still, I will give magnesium sulfate. This is your prophylactic magnesium sulfate. Prophylactic magnesium sulfate to prevent convulsion. No, this is not for neuroprotection beta. Neuroprotection, forget it. There, this is prophylactic for convulsion. This is given to prevent eclampsia. Because if you don't give, then patient will develop eclampsia. So please understand this. Many students only know Maxsulf is the drug of choice for eclampsia. Maxsulf is also the drug of choice for impending eclampsia. Clap if you have learned something new. Is it clear? So you are giving it prophylactically to prevent convulsion. And again, after giving magnesium sulfate, you can never wait. Is it clear? Never wait and watch. प्लीज अंडरस्टैंड दिस. लॉजिक ये है कि सर, इफ द पेशेंट इज 24 वीक्स, you can't say कि sir, let me wait and then at 32 weeks I will deliver. No, in that 6 weeks mother will die, baby will die. So never wait and watch. You cannot wait and watch, and delivery has to be done irrespective of weeks of gestation. Is this concept clear to all of you? Okay, delivery has to be done. Please write down in the bracket, delivery done irrespective of weeks of gestation. Is this crystal clear to all of you? Okay, इसके बाजू में you will draw 5 stars. So let in the question paper be 24 weeks, 36 weeks, 28 weeks. माँ और बच्चे में से mother is more important. Mother has to be saved, but max self has to be given. And when I say delivery, do not directly do LSCS. We will do induction of labor. You induce the labor. Okay, preferable, not direct LSCS. So now if I look at the question paper, all of you, let this patient be 31. Let it be 28, let it be 26. Answer will not change. I repeat, our diagnosis is impending eclampsia because of all this blurring of vision present. Wait and watch. Wrong. Similarly, labetalol I will give, but delivery at 34 weeks. Wrong. We are 31. You can't wait. And all those who said C is wrong. Yes, very good. Magnesium sulfate, very good. Labetalol, very good. But then delivery at 37 weeks. Wrong. You cannot wait. Very good. So D is the answer, sir. Magnesium sulfate, labetalol, and immediately induce the labor. But sir, 31 weeks baby may not survive. Okay, no problem. So let the question paper be 31, let it be 24, let it be 26, let it be 36. The answer will not change. Is this understood to all of you? Okay. Yeah, same. Prophylactic dose same. Okay. So Maxelf we will give. Labetalol I will give to control the blood pressure. And just remember the Maxelf is to prevent. Okay. Maxelf is given to prevent eclampsia. Okay. And then you will induction of labor because that is the definitive treatment. Is this clear to all of you? So all these are very, very important MCQ shortly coming in the exam. Okay. And yes, before we proceed further, quickly all of you please take 10 seconds to follow me on Insta and YouTube and Telegram. This entire PDF will be available on Telegram, and many of you might have just joined late, so just 30 seconds. Download the OGGuru app. Rapid revision live, fastest way to jump up your score from 10, 12, 13. If you're struggling in OBGY, beta, your score is going to jump up to 24, 25, 30. 30 MCQs are coming. Live classes starting from 8th December, Monday onwards. Okay. And just in 849 rupees, live sessions, 90 minutes. Whole day study, other subjects. Just come in the night, 90 minutes, evening time to revise. And if you miss the live classes, recording will also available. So just download the OGGuru app quickly. Download the OGGuru app from this link. Okay. Available on both Play Store and App Store, and you will do tremendously well. And for all my existing students, we have a special coupon code. All of you, I want you to join also. I'm going to see you live on 8th December onwards, evening time. Existing student के लिए only 240 and new student just 249. Okay, so very, very economical. We have kept it all 9 days session until the recordings will remember till 20th Jan. Okay, this course you can see repeat many time. Okay, this one, all session recordings will be available for revision later on also. Okay, till your exam date, starting from 8 December on. Okay, so that, yes. Now very important, in Pritchard regime the therapeutic range is 4 to 7. 4 to 7. Four to 7 milliequivalents per liter. Okay, 4 to 7 milliequivalents per liter is the answer. Now, can you tell me when the patient, first of all, what is the dose? Anybody, what is the dose of magnesium sulfate? What is the dose? Okay, the loading dose. Anybody initially? Yeah, very good. 14, how much better? 14 milligram gram. Gone, gaya. Tandigul. सच्ची चंदन चौहान, मिस्टेक एक हो गया, सब रॉन्ग, महर रॉन्ग. ओके, जिसने भी मिली, सी दिस इज हाउ यू आर मेकिंग मिस्टेक्स माय डियर स्टूडेंट. क्लीन बोल्ड. 14 grams. मैक्स सेल्फ का द लोडिंग डोज इज 14 grams. ओके, not milligram. 4 gram is given IV, and then 10 gram is given IM in each buttock, 5 and 5, and therefore it is 14 gram is the loading dose. Okay, and when the levels are more, what you monitor? Anybody? We have to monitor the knee jerks, respiratory rate, urine output. How much should be the urine output? Urine output should be at least 25 to 30 cc per hour. Okay, very important. We monitor knee jerks, respiratory rate, and urine output. Is this understood to all of you? Yes. Directly through the app. All of you can pay through the app. Okay. Yes. Now, again, a PYQ not virgin. This question has come in the exam. Okay. Anybody? 15-year-old, cyclical abdominal pain, urinary retention, primary amenorrhea, simplest MCQ. All of you should get it correct. Is this understood to all of you? So this is what, yes, because we are getting here what we are saying, bulging, bluish, purple, bulging hymen. Okay, yes. So that is imperforate hymen. Now anybody, yes, crypto means this is a cryptomenorrhea. Crypto matlab hidden. That's why cryptocurrency होता है, crypto matlab hidden. Okay, so please understand this. These patients are going to present with primary amenorrhea, and very quickly all of you should know क्या है ये. Sir, whenever the menses are there, sir, actually the menses is going to start. Sir, actually the menses start, but the blood is not able to come out. Blood is not able to come out because there is a imperforate hymen. So what will happen? Anybody? Yes, the blood will get collected inside the vagina, called as what? Hematocolpos. Further, upper blood gets collected, hematometra. And that is why this is a classical thing. Please pay attention. Cyclical abdominal pain. Okay, every month that pain hoga, like that primary pain is there, but the blood is not coming out. So when you give this cyclical abdominal pain, and anybody, why urinary retention? Many students don't know this. Why urinary retention? For what? This all hematocolpos can press the bladder. Yes, this hematocolpos can compress the bladder and can give rise to urinary retention episodes. Okay, is this clear to all of you? And perfectly correct. The treatment is cruciate incision. We will make a nick. We will make a nick over here, cruciate, and the blood starts coming out. Is this understood to all of you? Can you tell me one more condition? Because here, now look on the picture, all of you. Because this picture is there, because this bluish, purplish, bulging hymen is there, we are giving the answer as imperforate hymen. Very good, agree. Tell me one more condition in the question paper. Yes, it can, okay? Yes, because backflow. Anybody? One more condition where the same from the option. Septate uterus may you don't get this, and longitudinal vaginal septum will again not, because in longitudinal vaginal septum the blood can come out. All of you look on the board. If it's a longitudinal vaginal septum, okay, like this, if it's a longitudinal vaginal septum, the blood can still come out and there is no cryptomenorrhea. Yes, so transverse, but that's not answer is imperforate hymen, but transverse can also give rise to a, so because of this, okay, so transverse vaginal septum, maybe all of you look on the board, suppose there is a septum over here, the transverse vaginal septum, then it can give rise to similar. Okay, so is it clear? So transverse septum and imperforate hymen both can give rise to this, but because looking at the picture we are saying that this is better. This is the best answer to mark because it's a imperforate hymen. Okay, very good. Now very important, short again MCQ. क्या है diagnosis? Whenever I have a patient who has come to me at 36 weeks of pregnancy with bleeding, so bleeding in the third trimester, bleeding in the third trimester, bleeding in the third trimester, I need to keep 2 points in mind. What are those 2 points? Yes, sir. We need to either be placenta previa, or it could be abruption. And anybody, how is the difference? Placenta previa and abruption, how is the difference? So placenta previa is a painless bleeding, abruption is always painful. ठीक है, most important point. And here, sir, the uterus is relaxed. Uterus is relaxed, and in abruption the uterus is, yes, tender, is increase in the tone of the uterus. Okay, tonically contracted uterus. Yes. Okay, so anywhere if you read the word tonically contracted, okay, tonically contracted uterus, again blindly mark abruption. So all of you look on the board and you can see over here, sir, painless bleeding, profuse bleeding, and BP is normal and uterus is relaxed. So this is not eclampsia, this is placenta previa. No, we don't do LSCS, will depend on the baby condition, all that, not directly. Okay, mother condition, baby condition, all that. You can wait and watch. And the head is floating. Anybody what this floating head? ये floating head क्या है? And why is the head floating? Okay, and finally, how to deliver in placenta previa? Anybody? Okay, thank you. Okay, yes, very good. So the floating head is because the placenta is down, so it prevents the head from getting engaged. Okay, and therefore it is called as floating head. This is called as either the head is floating or unengaged, because floating means basically unengaged. Okay, floating kind of unengaged. Okay, unengaged. नो नॉर्मल वो बताएंगे बेटा डिलीवरी कैसे होगा. ओके, यस. सो नाउ टेल मी द आंसर. फर्स्ट ऑफ ऑल सेम थिंग. ओके, पेशेंट आई स्ट्रोक वी स्ट्रोक हो मतलब एडमिटेड इन व्यू ऑफ. अगेन अ शॉर्ट एमसीक्यू. चलो, फर्स्ट आई ओनली वांट द डायग्नोसिस. लॉन्गेस्ट क्वेश्चन, आई डोंट वांट द आंसर, आई ओनली वांट द डायग्नोसिस. वेरी गुड, वेरी गुड. नो बेटा, एनवीडी जिसने बताओ क्या. हाँ हाँ हाँ, बता. महनूर, महनूर. बट अभी देखो कैसे, आई विल एक्सप्लेन टू द कॉन्सेप्ट. ओके, सो प्लीज अंडरस्टैंड दिस के पॉइंट नंबर वन दैट दिस इज प्लासेंटा प्रीविया. वेरी गुड. PP, placenta previa. Why? Because all of you look on the board, painless bleeding. First clue. BP normal, because in abruption generally there is hypertension associated. Okay, abruption patients have generally preeclampsia, so BP will be high initially. Okay, uterus relaxed, head floating. So all these clues are telling me it is placenta previa. ठीक है. Now all of you look on the board. In placenta previa, this is the uterus, this is the placenta. Please pay attention. बेबी प्लासेंटा फाड़ के बाहर नहीं आता है. फटा प्लासेंटा, निकला बेबी. Not possible. The baby cannot perforate through the placenta. Is it clear? Vaginal delivery is not possible. There's going to be torrential bleeding. Okay, and therefore those who said vaginal delivery, jail. And therefore again, if you induce the labor, what will happen? Anybody? If I make the uterus contract, anybody? I should never induce the labor. You should go to jail. Is it clear? If you induce the labor, if you whoever will do this induction of labor, jail में डालो. जेल में डालो, because they are causing more mother to problem. Similarly, forceps delivery भी करेगा, not possible, jail. How will you apply the forceps? Forceps कैसे लगाओगे? पूरा placenta नीचे है. Is it clear? So remember, my dear student, that in placenta previa, the delivery finally will always be by LSCS. Okay, because baby cannot perforate, but that's not the answer over here. The answer सुनेंगे. Okay, so delivery is always by LSCS. Yes, but not best. It is the only option possible. But now all of you look on the board. We are how many weeks? Sir, we are only 33 weeks. Yes. So we are 33 weeks. So can I wait? Yes. Now look at the mother. Sir, mother is stable. Why? Yes, because hemoglobin is 11, BP is normal, and baby heart rate also 140 is normal. Very good. And therefore, wait and watch is the answer. There is no need of immediate cesarean section. We will wait and watch. Is this understood to all of you? Yes, because sir, and remember this all. And what is this called as anybody? When you wait and watch. Chalo, or ek MCQ. No, placenta will not change only in early. Okay, I will tell you when the placenta changes position. Okay, regimen of expected management. Expected matlab wait and watch. And what do you do in this expected management? Sir, you will give steroids to the mother. Why do we give steroids? Anybody? Steroids, why do we give? Yes, this is McAfee and Johnson. Why do we give steroids for? Steroids are given for the baby lung maturity. Steroids are given, bed rest is given. We will also give tocolysis so that there is no further contraction. Tocolysis, okay, and closely monitor the patient. Closely monitor. Don't go to your room and sleep. Okay, chalo, let's go for a movie. Okay, so give steroids, give bed rest, give tocolysis, and closely monitor. That is McAfee and Johnson regime. But, my dear student, when I want to do this McAfee and Johnson, most important, mother should be stable, isn't it? If the mother is not stable, wait and watch for what? For the mother to die. Then don't wait. समझ में आ रहा है? Sir, mother should be stable and there should be no fetal distress also. No fetal distress is also required. There should, because there's fetal distress, then what do you are waiting for? For the baby to die. So then don't wait. And pregnancy should be less than 36-37 weeks. Then only you will wait and watch. Is this understood to all of you? So look at our question paper. Sir, we are 33 weeks. Mother is stable, baby is stable, and therefore I will wait and watch. Is this understood to all of you? Now, can you tell me the answer? If I change one word, yes, no, not it's not about Surya Chand. It's not about irrespective of vitals. You have to check the vitals also. Yes. If the mother is not stable, you have to immediately go for cesarean. Yes. Okay. So tell me the answer. Suppose I tell you, patient of placenta previa, profuse bleeding, and mother in shock. Then what will you do? Yes, sir. If mother is in shock, then immediate LSCS. Of course, give blood. Give blood to the mother, stabilize, and then immediate LSCS. Then don't wait. Is it clear to all of you? Yes. But sir, here since we are 33 weeks, mother stable, baby stable, I can wait and watch is the answer. Now all of you tell me the answer. Suppose this one digit I change and 33 weeks, I make it into 37 weeks. Now what is the answer, all of you? That's why hashtag crystal clear concept. Mixed. Dr. FMGE spent very important MCQs. Go back and see the stream right from the beginning and do not miss out the lecture for anything. Very good. Sir, now since we are 37 weeks, now there is no point waiting. Now you no point in waiting. Okay. Placenta, so we are waiting only for the baby lung maturity. Placenta is not going to go up. So once you reach 37 weeks, then it is going to be cesarean section. Okay, nahi, induction nahi. Again wrong. Okay. Justin Doku, bataya maine. Who will do induction is jail. Yes, Kushal Kumar wrong, fail, jail mein dalo. Okay, is it clear? Vaginal delivery is not possible in placenta previa. Baby placenta फाड़ के बाहर नहीं आ सकता है. फटा placenta निकला baby. Okay, it is LSCS only. Is it clear? Previa is only by LSCS. Yes. So sir, if the patient is 37 weeks, I look on the board. If they tell you 37, 38 weeks, the answer is cesarean section, even if everything is stable. But since the question is 33 weeks, we will wait and watch. We will wait and watch. Is this clear? Because look at the heart rate. Heart rate is normal. BP is normal. Okay. The last thing, all of you pay attention. If this was the question, no. Okay, this was the question. Okay, in the 20-week sonography. In 20-week scan, if you say it is placenta previa, yes, then sir, because it is a 20 weeks only, as the uterus will become big, the placenta gets pulled along the lateral wall and placenta can migrate upwards. So here you don't say, sir, vaginal delivery, cesarean, ye nahi, sir. Here I will repeat the sonography. Repeat sonography at 30 weeks or 32 weeks and then decide. Is this crystal clear to all of you? Yes. Bed rest nahi beta. Placenta, you don't require bed rest. If it's not bleeding, it's okay. They can continue work. Yes. Is it clear to all of you? Yes. So whenever they tell you it's a 20 weeks previa, then yes, if you repeat the scan after 36 at around 32 weeks, it is clear. Clear? Okay. Yes. So McAfee and Johnson completely I have told you. No beta, low lying placenta, even in grade 1 also, 1, 2, 3, all we go for sections only in placenta previa. Unless if the edge of the placenta is 3-4 centimeters, then we can think of vaginal delivery. But then it's not a low lying, then it's called not previa, it's a low lying placenta. Okay. Yes. All are used in emergency contraception except. Thank you, Simran Sharma. Yes. Yes, so in emergency contraception, okay, all of you please pay attention. In emergency contraception, LNG 1.5 milligram. That is what our famous I pill. It's a brand name, but सबको पता होना चाहिए I pill. Very good, that can be used. Ulipristal is a newer, it's new. Here 1.5 milligram single tablet. Ulipristal is a selective progesterone receptor modulator. It is available till now. We can do up to 5 days as an emergency contraception. Okay, up to 5 days. Anybody with a dose? Anybody with a dose? Anybody with a dose? Ulipristal ka 30 milligram single dose, 30 milligram stat immediately as soon as after unprotected sexual intercourse. Okay, and IUCD can also be IUCD also be given? Yes, IUCD can also be inserted up to 5 days. Misoprostol is the answer. Misoprostol is not for emergency. Misoprostol is for MTP. Yes, when the pregnancy is already confirmed and she does not want the pregnancy. So either for MTP I can use it, or misoprostol also is for induction of labor, or we can also use misoprostol for postpartum hemorrhage also. Is this understood to all of you? So misoprostol is not for emergency contraception. Okay, again very important. Short match the column. Yes. Yes. So now please pay attention that, sir, yes, we can use for prevention. Okay. The McAfee and Johnson, I just now told you, it is for placenta previa. So 4 is B, 4D नहीं है, 4D नहीं है, 4 ही है. तो एक में ही आंसर पता चल गया. Okay. Burns-Marshall maneuver is what? Yes, Burns-Marshall, sir, is you will hold the baby. This is the breech. Okay, suppose the baby's head is in the birth canal and this is the mother lying down. You hold the baby by the lower limb and rotate it up towards the mother's abdomen, so the baby's head can pop down. Okay, baby's head can pop out. So Burns-Marshall is for after coming head of breech. So 1C, 1C, 1C. तो ये गया. Yes. Wood's maneuver is one, just the name remember. Wood's maneuver is for shoulder dystocia, 2F. And anybody 3A, cochlear uterus. Cochlear uterus is seen in abruption. Anybody? And what is it? Or yes, okay. So can you tell me what is cochlear uterus and which type of aberration we get? Anybody? Yes, all of you please pay attention. Okay, sir, if this is the uterus, all of you look on the board. And if this is the uterus, and there the placenta has detached and there is abruption, but concealed abruption. There is no space for the blood to go out if it's a concealed variety of abruption. Okay, the placenta is completely blocking. Okay, okay, if there is concealed abruption, then what will happen? Anybody? What will happen? Yes, the blood will go retrograde. The blood will go retrograde in between the muscle fibers and the uterus will start appearing bluish purplish in color. Yes, uterus starts appearing bluish purplish mulberry, which is your cochlear uterus. Okay, so C for cochlear, C for concealed, that is the cochlear uterus. Is this understood to all of you? And anybody, what is the treatment for this? इसको क्या करना है? So cochlear uterus in concealed abruption. If the blood is coming out, all this problem will not happen. Okay, if the blood is coming out, not in revealed variety. Okay, not in revealed, in concealed variety. And please understand this. This is the diagnosis which I make on my operation table. Okay, which is a diagnosis made on operation table at a time of cesarean section. Nothing to be done. Nothing. You will not say surf excel के sister give me Nirma washing powder surf excel धो डाला कि sir will wash the uterus को चकाचक कर देंगे uterus को धो डाला नहीं वो सब कुछ नहीं करना है. Okay, you just have to wait and watch. Yes, no treatment required. Very good. Okay, concealed abruption, it shows on the abdomen. No beta, this is on the uterus. Beta concept success 740. Cochlear uterus. When you will open up the abdomen, you at the time of cesarean you will say अरे ये तो uterus blue हो गया है. It's a retrograde. The blue uterus becomes bluish. Uterus will become bluish purplish. That is called as cochlear uterus. Okay, and very good. No treatment is required. Just deposit the uterus back in, come back home. After a few days, this will disappear and the color will come back to normal. Okay, so no treatment is required. Yeah, if there are no symptoms, yes, unless it's a PPH, then it's okay. So remember, this diagnosis is made on OT table. The diagnosis is made at the time of LSCS. After LSCS, diagnosis at the LSCS. Okay, generally. So when you open up the abdomen and you see कि अरे after delivery ये तो uterus blue पड़ गया है. Okay, yes, very simple MCQ. चलो, tell me the answer. What is the diagnosis? Anybody? What is the diagnosis? Sir, very simple. After the placenta delivery, the patient starts bleeding heavily and the uterus is flabby. What is it? Sir, it is not only PPH clap, it is atonic PPH. And for atonic PPH, oxytocin is considered the first drug of choice. Then we can also give methyl ergometrin, prostaglandin, misoprostol can be given. Answer is mifepristone. Has nothing to do. Mifepristone is for MTP, isn't it? Okay. Yes. Thank you. Okay. Now can anybody tell me what is this carbetocin? So meso can be given oxytocin. And when all the medical method fail, what do you do? Okay. after all the medical, so first you go for medical management for PPH, and then if they fail, what is to be done? Last 2 years, okay, last 2 years this question is coming. Before going for surgical management, before starting surgical, नहीं उसके पहले, even before ligating, yes, tick tube city, balloon tamponade, very very important, either condom tamponade or bakri balloon or balloon tamponade. Please remember, okay, so PPH whole will discuss in our actual lectures, okay, so please see that, okay. So it's very important, okay, sir, first we try medical management, if it fails then we do balloon tamponade, and then if it fails we go for surgical management. Is this understood to all of you? Yes. So misoprostol can be given, which is PGE1, and one more we can give PGF2 alpha, which is carboprost, वो भी okay है. So oxytocin, methyl ergometrin, tranexamic acid also we give overall to control the bleeding, tranexamic acid don't forget, and PGE1, PGF2 alpha, all we give, and oxytocin. Now the question to all of you है, carbetocin क्या है? Carbetocin क्या है? Nobody told me this. Answer is mifepristone. So what is this carbetocin? Anybody? Sure shot MCQ. Virgin MCQ. Sir, carbetocin is a new drug. It is a oxytocin derivative. But what? Yes. Okay, sir, the problem with oxytocin, highest level of gynec which anybody can teach you, the problem with oxytocin is oxytocin requires refrigeration, and for oxytocin, proper cold chain has to be maintained. Oxytocin has to be in proper cold chain, refrigeration, and carbetocin, sir, carbetocin is a derivative of oxytocin which is stable at room temperature. Is this understood to all of you? Very good. It's not a tocolytic. No, Piyush, but a tocolytic is different. It's a utrotonic agent. Utrotonic, yes, but stable at room temperature. Okay. So oxytocin derivative, but stable at room temperature, carbetocin. Okay. Clear to all of you? Yes. Now tell me the answer. What is this? Patient is having 2 months amenorrhea. Uterus is empty and HCG. So what will you think? Sir, if the patient is pregnant, isn't the pregnant patient, because HCG is 1500, and you are getting a right-sided mass of 2.5 by 3 centimeter. What is diagnosis? Wrong. बेटा मोलार में नहीं. Wrong. क्या बात है? मोलार में तो snowstorm appearance. Why will the uterus be empty? Yes, this is our ectopic pregnancy, because sir, whenever beta HCG positive or urine pregnancy test positive, but uterus is empty, this, and you see a mass outside the uterus. But all of you, yes, very good, better your answer. This is unruptured ectopic pregnancy. Why I am saying unruptured ectopic? Because sir, pulse stable, BP stable, hemoglobin 11. So this is unruptured ectopic pregnancy. You don't need, okay, in unruptured ectopic pregnancy, who will wait and watch? Repeat USG after 2 weeks. In that the ectopic will rupture. So if you wait for 2 weeks, you have to go to jail. You can't wait for 2 weeks. Okay. You can't save the tube. Okay. Yes. Okay. So what is, okay. Yes. So patient is stable, and what is our criteria? Yes. Okay, sir, and this is the mass is seen. Okay, they've said 2.5 by 3. Okay, 2.5 by 3. Okay, so multiply nahi karna hai. 2.5 is one dimension, 3 is another dimension. Methotrexate is always preferred. What are the criteria? Okay. No, beta, Mr. Techino. Okay, what are the criteria for giving methotrexate? Sir, of course, patient should be stable. That means it should be a unruptured ectopic. Second, gestational sac will be less than 4 centimeter. Gestational sac will be less than 4 centimeter. Okay, and HCG values should be less than 5000, isn't it? Micro international units per ml. If all these criterias are satisfied, we will, yes, and preferably cardiac activity absent, then we go for methotrexate. Why methotrexate? Because it is unruptured ectopic. If it's a ruptured ectopic, then I have to do immediate, sir. We'll discuss that also. There's MCQ about that also. Okay. After methotrexate, we have to monitor the HCG levels. Methotrexate will kill the pregnancy. After methotrexate, HCG level has to keep on coming down, coming down, coming down. Okay, is it clear? So please remember, this is a short MCQ. Remember that patient should be stable. SAC criteria and HCG levels. Twin delivery and पता चला कि ये तो इसके ऊपर पिक्चर भी बन गया. There was a movie on this recently. Yes, anybody? Good news, bad news. movie था कि paternity testing, one baby is of the husband and one baby is of the neighbor. अरे बाप रे, ये क्या हो गया? So please understand this. Remember this, that superfetation is not possible in humans. Okay, now what is this is, please pay attention. What happens in this story? It's a release of two ova, but in the same cycle. So two ova are released in the same cycle, but fertilized by different act of coitus by same or different partner. So in the night the wife has sex with the husband, and in the morning the husband goes out and the neighbor enters. Okay, and again sex with another partner. So there will be twins, but they are released by different partners, different act of sex, but same cycle, both the eggs are released. This is superfecundation. Okay, yes, different acts of, okay, very good. Okay, but different cycle, two over same cycle, different acts of coitus. Okay, is this clear to all of you? Yes. Okay, in superfetation, the ovas are released in different cycle. One cycle, one pregnancy, implant baby, fetus ke upar fetus. Okay, yes, and then the again ovulation in the next cycle. So all that is not possible in humans once the pregnancy happens. So this is superfetation nahi hai. Okay, this is superfecundation. Okay. Yes, is it clear to all of you? Yes. So this is very important. Again, a PYQ test come. Okay, superfetation mein one baby already starts growing, and then another egg is released, and then another baby ke upar baby. There's a one cycle gap. So all that is not allowed. Okay, all that is not allowed. All that is not possible in humans. Okay, yes. So this is superfet. Yes. Now again, a very important MCQ. Patient is 47-year-old. Is very sure. Tell me the answer. Okay. Yes. Now please pay attention. The important part is never. How many want to go for D directly? Wrong. Never directly proceed for hysterectomy. I'm not saying don't do. I'm saying never directly. Why? Because please understand this. The important point is that this is perimenopausal. And please understand this, the trick part. All of you tell me, will this 2 centimeter subserosal fibroid cause menorrhagia? Never. So this, yes, sir, in this question, this subserosal fibroid is just given to distract the student. Okay, no need to remove the fibroid, Piyush, wrong. So myomectomy is not going to solve the problem. Okay, myomectomy is not required because it's a subserosal fibroid. This will not cause no symptoms. This does not cause any symptom. It's a 2 centimeter subserosal chin to fibroid outside. ये कुछ नहीं करेगा. Very good, Sachin Chaudhary. Okay, here you have to think that, sir, then why this 47-year-old who is perimenopausal is getting menorrhagia? Sir, is there some problem with the endometrium? Yes, and therefore, whenever I have got a perimenopausal lady who is having heavy menstrual bleeding, histopath diagnosis is compulsory. Histopathological examination of the endometrium is mandatory. Write down these words. Why mandatory? To rule out endometrial hyperplasia, endometrial cancer first. Is this understood to all of you? Okay, HPE is mandatory. You will rule out hyperplasia question first. Okay, is this clear to all of you? Okay, and therefore you will go for either dilatation and curettage, या endometrial biopsy, या hysteroscopy and biopsy. Okay, hysteroscopy. Why? Because sir, if I do the direct hysterectomy, is it clear? Sir, if directly I remove the uterus and the report is cancer, you have done inadequate surgery. Because menorrhagia, you remove only uterus, cervix. Cancer endometrium, you remove uterus, cervix, fallopian tube, lymph, all that. So which hysterectomy karna hai? Sada, masala, all that. Yes, definitive management, Dr. Albert, will depends on the histopath report. Yes, if the DNC is hyperplasia, we prefer to do hysterectomy. DNC is cancer, radical hysterectomy, even radiotherapy afterwards. Okay, and if nothing is there, then you can try progesterone. Okay, so never wait and watch, and never directly to hysterectomy. Myomectomy has got no role over here. Is this clear to all of you? Yes. So first we need to do a DNC or a hysteroscopy and biopsy. Why? To rule out endometrial hyperplasia and cancer first. Always rule out endometrial hyperplasia, cancer first. Now chalo, tell me, ये क्या है? कोई मुझे बोल रहा था. Okay, this is your terrace view from above. From above, we are seeing the uterus. This is the ovary. This we have held the fallopian tube. And what is this blue dye coming out? So this is the methylene blue dye. This is the methylene blue dye, which is the best investigation or gold standard. This is laparoscopy chromoperturbation. It's the best investigation or confirm for tubal patency. Okay, don't get confused. We don't do hysteroscopy. It's just blue color देके hysteroscopy with methylene. Hysteroscopy में methylene blue नहीं होता है. It's a laparoscopy view. Okay, clear. So actual students should have a concept of what is hysteroscopy, what is laparoscopy. In hysteroscopy, we are putting the telescope inside the uterus. ये आपको बाहर का view है. Here clearly you are seeing the uterus, fallopian tube, ovary. So this is your laparoscopy view, isn't it? And laparoscopy, when I put the dye, which is the dye, methylene blue dye, and you can check if the blue color dye is coming out, isn't it? That is your, yes, it's a test for tubal patency, not ectopic pregnancy, it's a test for tubal patency. Okay, whether tubes are patent, infertile patient you do this. Okay, so you are going to put the dye. Okay, it's like this. Okay, sir, this is the uterus, and you push the dye. And then you see, we are putting in a telescope. We are putting in a telescope from above, and the methylene blue dye I will inject. The blue color dye I will inject inside. And if the tube is patent, the dye will come out from here. Okay, like that. And that is called the spill of the dye. Okay, yes. Again, a very important MCQ. The most common anomaly in the baby of the diabetic mother. Okay, so the answer is not option 1. VSD is the most common. The sacral agenesis, or also called as caudal regression syndrome, is the most specific. The most specific anomaly on the baby of the diabetic mother. Is this understood to all of you? So please don't make a mistake in this. Okay, most specific is sacral agenesis or caudal regression syndrome. Most common is VSD, and we also have a neural tube defect like your anencephaly spina bifida. That's second most common. Yes, now this is just to confirm, just to repeat the whole thing. All are tocolytics except What are tocolytics? Uterine relaxants. When do we give it? Sir, tocolytics. If you know the answer, if you paid attention just 1 minute ago, all of you wrong, wrong, wrong. क्या हो रहा है? Clean bold. So ritodrin is a beta 2 agonist. Very good. It is a tocolytic agent. Nifedipine is a calcium channel blocker. It is also a tocolytic. Anybody? Calcium channel blocker, CCB. Anybody? What is atosiban? Very important. Sir, atosiban is a oxytocin antagonist. And magnesium sulfate, yes, also has a tocolytic property. Okay, magnesium sulfate also has a tocolytic property, though rarely used. Okay, answer clear cut. I told you carbetocin is what? It's a oxytocin derivative. It is used for PPH. I told you carbetocin, one and only one use. Okay, carbetocin is for prevention and treatment of PPH. It's a oxytocin derivative. Oxytocin derivative, which is stable at room temperature. I told you. Okay, stable at room temperature. Yes, previous question only I have discussed, but still students, sometimes if you are not paying attention in the exam, you will lose the mark. So all these are our tocolytic agents, including also indomethacin also. Okay, so magnesium sulfate is not only the drug of choice for eclampsia, it is also for impending eclampsia. Impending eclampsia, never wait and watch. Carbetocin is a uterotonic. Okay, यहाँ पे tocolytic का बात हो रहा है. Yes, again simple, but many students make a mistake. All are part of AMCEL's criteria except yes. So sir, AMCEL's criteria is for diagnosis of bacterial vaginosis or vaginitis and grayish white discharge, positive whiff test, presence of clue cell, but pH, vaginal pH, या vaginal fluid, vaginal pH basically is not less than 4.7. Okay, the bacterial vagina grows in the acidic pH. Yes, the pH is not, it has to be more than a basic. Okay, Candidiasis is the only one which grows in acidic pH. Okay, so pH is not only this arrow sign. Okay, so remember bacterial for bacterial vaginosis or bacterial vaginitis, the pH is not less than 4.5. Less than 4.5 is favorable for candidiasis. Okay, acidic. For BV, the pH will be more than 4.7. Is it clear to all of you? Yes, metronidazole is the drug of choice. So just remember this. It is just this sign. Just this sign के वजह से your marks can go wrong. Okay, is it clear? So don't make a mistake in this sign. Okay, answer is this, except पूछा है. So vaginal pH not less, it has to be more. Okay, clear to all of you? Yes. Moving on. Again, now tell me the diagnosis. So both I have taught you. Emergency room, 2 months amenorrhea with severe pain in abdomen and shock. BP 90/60, hemoglobin 6, urine test positive. What is the diagnosis? Okay, so my dear student, what is the dictum? Sir, shock in early pregnancy, all of you, shock in early pregnancy is because of ruptured ectopic pregnancy, unless proven otherwise. Is this understood to all of you? Keep this very, that in sir, early pregnancy, when the patient comes to us with shock, it is always ruptured ectopic unless you prove it otherwise. That means always first think of ectopic pregnancy, ruptured. Okay, now please understand this. The question is just to confuse the student. Next, immediately what do I do? Yes, And definitive treatment is what? So here you can't give methotrexate. Methotrexate is not in shock. Here the patient is in shock. Okay, methotrexate is only for unruptured ectopic pregnancy. Okay, is it clear to all of you? Okay, so methotrexate cannot be given over here. It is for unruptured ectopic pregnancy. Okay, and now what will you immediately do? Okay, yes, please understand this. No, all that is okay. Now please understand this. Immediately, 2 wide bore IV line, you have to give 2 wide bore IV line, collect blood for cross match, start IV fluids. Okay, and immediately shift to OT. You have to shift to the operation theater, and laparotomy and salpingectomy is the gold standard surgery. Please don't feel bad that, oh, you are cutting off patients one tube. Another tube is enough to cause population explosion. Okay, one tube is enough to cause population explosion. So please understand this. ये आपने कहाँ से ये सब wrong? Salpingotomy we don't do. Answer is salpingectomy. Always remember, for ruptured ectopic we cannot save the tube, because this whole tube is stone. It's a ruptured ectopic. The whole tube has blasted and there's torrential bleeding. So till the time you clamp the tube and get the whole tube out, the bleeding will not stop. Is this understood to all of you? And therefore, my dear student, salpingectomy, remember, is the gold standard surgery for ruptured ectopic pregnancy. Is this understood to all of you? Ruptured ectopic salpingectomy. Yes, salpingotomy and all that, first of all, cannot be done in ruptured. And all that is kachra dustbin, because in salpingotomy you are only cutting the tube, removing ectopic, keeping the and suturing the tube back. There will again be repeat ectopic. So salpingotomy will lead to again ectopic pregnancy on the same side. So all these are not done. And when the patient is in shock, laparotomy is preferred. Is this clear to all of you? So you only remember 2 things: ruptured ectopic, a shock patient, laparotomy, salpingectomy; unruptured ectopic, methotrexate. Okay, clear to all of you? And very, very important. Yeah, spelling you have to clear. Yes, salpingectomy, salpingotomy. So if you have not seen the spellings, you will go wrong. Yes, and this is like a yes. Is it clear to all of you? Now again, this is like a revision. If you have seen all the previous lectures before now, today only, sir, for ovarian torsion, color Doppler. So 3C, 3C, 3C. Okay, just for fibroids, only fibroids, sonography is okay. So 4D, 4D. Okay, yes. Asherman syndrome is what? All of you, I told you, sir, Asherman syndrome is intrauterine adhesions. And Asherman syndrome, intrauterine adhesions, we require hysteroscopy. Hysteroscopy is to be done for Asherman. So 2A, 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 2A. So what is your answer, all of you? Yes. Okay, so ye out, ye out. And endometriosis, I told you, we will see chocolate cyst, blueberry, red raspberry. Endometriosis, laparoscopy is the preferred investigation. 1B, 1B, 2A, 3C, 4D. Yes, option C is the answer. The very important MCQ. Here are our different conditions and here are the preferred investigation. So Asherman syndrome के लिए I need to do hysteroscopy. Endometriosis के लिए, to see the chocolate cyst, I need to see the endometriotic implants. They are called as endometriotic implants. Endometriotic implants and chocolate cyst. Okay, chocolate cyst, all that we will see with laparoscopy. So endometriosis requires laparoscopy, and simultaneously I can also do the surgery for endometrial patient. Okay, so 1B, 2A, torsion के लिए कलर डॉपलर, नॉर्मल चेस्ट फाइब्रॉइड, सोनोग्राफी इज ओके. ठीक है, ये 1B नहीं. ओके, इज इट क्लियर टू ऑल ऑफ यू? 3D नहीं है. ओके, Yes, so C is the answer. Okay, is this clear? Yes, yes, yes. And all of you see this beautiful handwritten notes. All of you will get inside the app. All student has told me, okay, sir, completely color integrated images. Every student has told me, okay, sir, once you have listened to all your lectures, the notes you can revise in 2 to 3 hours is my guarantee. So beautiful handwritten notes are there. Superb. And my dear student, it's your final chance. As I repeat, 30 to 35 mcqs, forget 35, 30 mcqs surely are going to come in the jan fmg examination, and many students get stuck at the score of 15-20. They're getting score of 130, 145, and then they take the lecture and then they jump up. The score is definitely going to jump up. So all of you quickly download the OGGuru app, and from 8th December onwards, every day live lectures, 9 sessions, 90 minutes. Okay, this 9 sessions, 90 minutes could be life changing and game changing for you. Okay, so many students last year had joined and they called me, and you will call me and thank me that, sir, among all 19 subjects, my best performance is in OBGY. And we 1 month before the exam, 8th December to 17th December. Okay, 17th, by 17th December we will finish off the whole course. So 1 month before your exam, your entire OBGY revision will be done completely. Imagine if this 3-hour session, if this 3-hour session has benefited you so much, imagine how much benefit you will get in the 15-16 hour session. And as I said, don't worry, whichever source OBGY you have studied, it's not going to conflict. Whichever source OBGY you have studied, this is going to add on. The students love my style of MCQ discussion. So it's going to be completely MCQs, PYQs, IBQs, and as I said, PYQs will be covered not only of FMGE, NEET, PG, PYQs will also be done. So live doubt solving, all session recording will be available. Notes, what I showed you, is going to be available, and notes read along session also we are going to see, and just in 849 rupees. Okay, so download the OGGuru app right away, and I'll be seeing you live on 8th of December inside the app. And for all those who have taken any packages in the past, whichever package you have taken, you can just avail it only for all my dear students. All 10 sessions are going to be only into 25 rupees per day. Is this clear to all of you? Yes, नॉर्थ सिटी के लिए भी ये बहुत काम आएगा आपको, and definitely. Okay, so here's this OGGuru signing off. OG in the chat box, please share this video with all your friends and colleagues. Please see the review. Students have said that, sir, because of OBGY we are able to cross the barrier, and we are able to cross. And I wish all of you best of luck. All of you will do very well in the examination. Keep cool, keep calm. See my strategy video also. Start following on Insta and on YouTube channel. I made a strategy video for FMG. You can go and see that, and the PDF will be available on Telegram. So quickly join the Telegram channel. Just take 10 seconds quickly with your mobile phone right away. And all of you, I want you to enroll in this rapid revision course, which is starting from 8 December in the evening. Whole day, please, whole day study other subjects. I'm only telling you, whole day study other subjects, study medicine, micropatho. In the evening time, just come 90 minutes, spend time topic wise. We are going to discuss topic wise MCQs of all the PYQs, image based, clinical, everything will be covered. Gynecology, 3 to 4 sessions, obstetric 4 to 5 sessions, totally 9 sessions. It's what we are going to do. Is this understood to all of you? Here's wishing you bye bye, best of luck. Thank you very much, and wishing you all the best for upcoming examination, and best of luck for the exams. Thank you.